Test. Hello, welcome everybody. Good morning. Good morning. I hope you are enjoying your breakfast. My name is Abe Layden. I'm one of 3 Douglas County commissioners, and I wanted to welcome you to the Douglas County Mental Health Initiative. Before we begin, I would like to invite up Pastor Mike Pahemis from The Rock. I will just tell you, regardless of your faith background, this is an individual that's deeply committed to mental health in this community and ensuring that we all have a sense of wellness. So we'll have Mike come up and provide a brief invocation. Thanks, Mike. Yeah, I didn't say brief.
Nobody told me it was brief. When you get a pastor up here, nothing's brief. So I'm just gonna start it off with prayer here, and I want to read. I'm going to read Romans 12, 9 through 16. I'm going to read these verses and then just pray into it. But we serve a great God, and I believe in these times, we need him more than ever. So this is what it says, and I feel like this is a great word for all of us in these times. Don't just pretend to love others, but let the inner movement of your heart always be to love one another. Despise what is wrong and embrace everything that is good and virtuous. Be devoted to tenderly loving one another with genuine affection. I love this part. Try to outdo yourselves in respect and honor of one another. Never be lazy, but be enthusiastic to serve the Lord, keeping your passion toward him boiling hot. Let this hope burst forth within you, releasing a continual joy. Don't give up in a time of trouble, but commune in prayer with God at all times. Take a constant interest in the needs of God's beloved people and respond by helping them. Always be eager to practice hospitality. Bless those who persecute you. Don't curse them. Pray that God will bless them. Celebrate with those who celebrate, and weep with those who grieve. Live in harmony with each other, and be mindful of one another's worth as you are with your own. Don't live with a lofty mindset, thinking that you're too important to serve others, but associate with the lowly and identify with those who are humble-minded. Don't think for a moment that you know it all. So, Lord, this morning, I thank you for this opportunity we have to come together, to celebrate this unity of a community coming together and serving those that are in need. Lord, I pray that you would continue to give us your heart for others, that we would love as you loved, with a laid down sacrificial love, putting others above ourselves. And Father, I thank you that we're going to do that in a spirit of unity, that we're going to do it with oneness, coming alongside each other, that we realize we can't do this alone. We never meant to do it alone. And even as we're going to see today, the importance of working together as one. So, Father, I pray that we would have our eyes on you, that we would be linked together, and that you would bless the things that we put our hands to as we have your heart in this time. In Jesus' name, amen.
Thank you very much, Mike. And I think Mike is so representative of so many partners we have in the faith community, regardless of your background. It's really a wonderful testament to how connected these pastors and ministers are to our mental health. Well, I would have to say, is there anybody in this room that couldn't use a mental health day? I'm going to put my hand down. My goodness, after 18 months, we are so incredibly thankful that all of you are here with us today. And if you are an elected official in the room, could you just stand up so that we could recognize you? Let's see, I think we have Coroner Jill Roman. We have our 2 commissioners. We've got Mayor Tara Radloff from Castle Pines, and we have Laura Hefta from the town of Parker. Let's give them a round of applause, guys. Today we're here to honor and celebrate the journey that all of you have been on. And for many of us in this room, you're caretakers, you're leaders in this community. And you have probably seen people that have struggled. You have worked with people that have been challenged. You've probably lost people either personally or worked with those that certainly have struggled over the last 18 months and before. We know that mental health is so critically important for all of us. And we often say in Douglas County, it's important to also care for the caretakers. And all of you in this room are also caretakers that are out there as bright lights in our community, making sure that we are doing well and succeeding in our roles. So we're here to celebrate the Mental Health Initiative, the community response teams, the CARE Compact, certainly the year of work we put into 988 legislation and ensuring that there are a lot of solutions associated with mental health that we can all celebrate. But what I'd like to do is maybe just level set. If we can all just stand up and begin with a little wellness. Let's all just stand up real quickly. And what we're going to just reach your hands up into the air, real big stretch. And what we're going to do is just, release your hands. What we're going to do is just breathe in for 5 seconds. We're going to breathe in gratitude, joy, and peace. And then we are going to breathe out any negativity, upset. I'm going to take off my title right here. We're going to take off politics. We're just going to focus on wellness and mental health. So let's just breathe in that joy for 5 seconds. Breathe in real deep. Good, and then let's just exhale for 3 seconds. Let's breathe in again. 5 seconds, breathe in that joy, that gratitude, that peace. And in 3 seconds, just release that negativity. Release 18 months of just yuck. And the last time, do it real well. Let's breathe in 5 seconds of just really good energy, positivity, this beautiful day, and then breathe out anything that you need to release. Thanks, guys, and I'd like to welcome up Commissioner Thomas to begin us on our journey today.
Good morning, everybody, and thank you, Abe. So I'm Douglas County Commissioner Laura Thomas, and I would like to welcome everybody who is here in the room and remotely. And I want to tell you why this is so important, that we are all here today working on this. I was the elected coroner in Douglas County from 2011 to 2015. In 2014, we were called to a horrific murder-suicide case. This was a case with a young man with severe mental illness problems, and his mother had been working with the county to get her son help, and his case fell through the cracks. He didn't get the help that he needed. He was able to get a hold of his mother's firearm that night. She was a single mom raising 4 children. Her husband had taken his life because he also had mental illness. The young man, Robert, shot his mother, chased his sisters around the house. One of his sisters jumped out the window, the second floor of her bedroom, and broke her back. She's now paralyzed. The other sister laid under the bed on the phone, begging for help from the sheriff's department. Robert went downstairs where his mother was and took his life. After that, Douglas County came together and said, "This is Douglas County, and we are going to solve this problem." Barbara Drake led the cause, bringing many of you here together to the same table. We have mown down silos, and we have 40-plus partners who are all rowing in the same direction because we know that there is help and there is hope, and that we can make people, we can show people the way so that their lives are better, and the support teams around them have better lives as well. And all of you have proven that can happen. We know that the suicide numbers in Douglas County were lower in 2019 than they were in 2018. They were lower in 2020 than they were in 2019. And the coroner recently told us that they have had so far 34 suicides. Last year there were over 50. So I think that your work together is making a difference. So thank you for being here. I also have the pleasure of serving on the state's new Behavioral Health Transformation Task Force subpanel. What that means is that the federal government has given the state millions, in fact, billions of dollars. The state legislature put $450 million towards mental health. Right now, there is a task force of 25 legislators. It is supported by 25 other people on the sub-panel. I was nominated to be on that committee to represent council people and commissioners across the state. In fact, there's a call going on today from 9 to 3. So after we're done with this section, I'm going to be listening to this meeting because we need to figure out how we spend this $450 million from the state in ways that support all of the work each and every one of you are doing. So now it is my personal and professional privilege to represent Colorado counties to help ensure access to behavioral health and substance use disorder services for all. As demonstrated by my support for the sustainability of Douglas County's mental health initiative and its programs, as well as my decade-long dedication to suicide prevention, I care deeply about this public health issue and its impacts. It's now my pleasure to introduce the next speakers. And I understand they're going to be here remotely. The first one is Shannon Breitzman, who is the principal of HMA Associates. I had a contract working with the state health department for 7 years on a project that researched homicide and suicide. That's where I first met Shannon. She was a bright star then, and she has become even brighter, and we are very honored to be able to continue working with Shannon. She's an agile public health professional with expertise in marijuana legislation, opioid abuse, injury and violent prevention, and behavioral health promotion. Trained in collective impact and lean facilitation methods, Shannon has a collaborative approach. She bridges mindsets and jurisdictions, crafting solutions to address shared risk and protective factors across multiple public health issues. Shannon coordinated the development and implementation of the statewide violence and injury, mental health, and substance abuse prevention and intervention initiatives for the Colorado Department of Health and Public Safety, for the Colorado Department of Public Health and Environment for 15 years. As a branch chief, she led the development of the nation's first state retail marijuana education and prevention program and campaign, now an award-winning national model. Shannon understands the complexities of legalizing recreational marijuana and how to proactively mitigate potential post-legalization outcomes. Stakeholder engagement is a specialty. Shannon rallied human services, healthcare, business and education partners statewide to embrace a child abuse prevention project that changed the paradigm from intervening with troubled families to building strong families through system and policy change. She brought together law enforcement, treatment, and public health officials with previously divergent points of view to develop a coordinated plan to counter the state's growing heroin epidemic. Shannon has 2 master's degrees from Notre Dame de Moore University in California and a bachelor's degree from the University of the Pacific. Shannon, are you online already?
I am here. Can you hear me?
Welcome, Shannon.
Thank
The
you.
next speaker is Laura Cinconi. Laura will be on the panel as well. Laura Cinconi is the Mental Health Initiative Coordinator for Douglas County, Colorado, where she works at the intersection of local government, public health, and behavioral health. Laura's primary role is working closely with Douglas County Mental Health Initiative partners, many of you here in the room, and guiding strategic initiatives aligned with the vision of a community-based integrated mental health delivery system. This intentional, partner-driven work spans health promotion, prevention, early intervention, crisis, acute, and long-term care, and relies heavily on the passion and dedication of community partners. Laura holds a Bachelor of Arts degree in anthropology with a social and medical focus, and a Master of Public Health degree from Indiana University Bloomington, which fed her interests in human behavior and health, and influenced her professional approach to community-based engagement and population health initiatives, including the impact of systems, institutions, and social determinants on health. Laura has watched the Douglas County Mental Health Initiative grow from its early stages through various program implementation cycles and into the diverse group of over 40 stakeholders that it is today. She feels incredibly lucky to have found a role that combines her interests in mental health along with her training in public health. She is encouraged by the ever-growing recognition of mental well-being as central to overall health and the power of community collaboration to create meaningful change at the local level. Laura? Are you online, Laura?
I'm here. Thank you, Commissioner.
Okay. So you two are going to be presenting together on your panel about the power of community collaboration. Thank you, everybody.
Thank you so much, Commissioner Thomas. And I'm so sorry not to be able to be there with you in person. I had really hoped to be there, but woke up this morning with sick kids and the sniffles myself, and thought as a public health person, it's best not to show up in person and potentially spread something that we're not sure what it is yet. So I apologize not to be there. Can everybody see and hear me okay? I assume somebody will let us know if you cannot. To set the context for why we're talking about collaboration and the importance of collaboration, I first wanted to get into addressing the challenges of behavioral health and why collaboration really is key and critical, and not just the challenges, but really what are the opportunities in behavioral health. So let's go to the next slide, Laura. So often when people think about mental health, they think about individuals with a mental illness. And I really like to show this model because this model, I think, really shows a more complete picture. It shows a dual axis of mental health. And on one axis, you can see one end that really reflects high levels of mental illness, so an individual with a serious mental illness. And then on the other axis, you see sort of low levels of mental illness. And then on the other axis, you see great mental health, so really flourishing with your mental health. And then on the other end, you see poor mental health, so sort of languishing or not doing well. And then the boxes, which I imagine are probably maybe hard to see or hard to read what's in the boxes, really just describe kind of what it's like to be in these different places along this continuum or in this model. And so what's important here to understand is that a person with a serious mental illness can experience good mental health because their mental illness is being treated, it's being managed, they're getting the supports that they need in the community. And then a person with no mental illness at all can be experiencing very poor mental health. And so, it just really reflects the complexity when it comes to our mental health and the needs that people have, and shows sort of a bigger picture of mental health and why it's important to have a full range of partners. Let's go to the next slide. And, we know that mental health problems are the single largest cause of disabilities in the world. Together, an estimated 20% of lost healthy days are due to mental illness, and globally, only an estimated 10% of people who need attention or treatment for mental health problems receive it. In Colorado, the picture is pretty similar. So according to the 2019 Colorado Health Assessment, 15.3% of Coloradans reported poor mental health, compared with 11.8% in 2017. Now, additionally, 26.9% of Colorado adults said that they or a loved one or a close friend had been addicted to alcohol or drugs in their lifetime. Mental health is as important as physical health in consideration of overall health. Poor mental health or mental illness increases the risk of many chronic physical health conditions like stroke or type 2 diabetes or heart disease, Similarly, the presence of chronic conditions can increase the risk of poor mental health or mental illness. So this slide here shows the continuum of behavioral health and where different partners might have a role along that continuum. Individuals can move along this continuum with regard to their need, and communities really should be equipped to offer programming and services along this continuum. So from community-based prevention programs and the promotion of good mental health, early identification of issues with mental health or substance use and early intervention, all the way through treatment, potentially residential services or acute care, and recovery and relapse prevention. So let's go to the next slide. And then I wanted to point out here, also in Colorado, there are, and this is true across the nation, this isn't unique to Colorado necessarily, but there are additional challenges along that continuum that have been very well documented, and significant reform efforts that you've heard about already this morning are underway in Colorado. You're going to hear about it even more a little bit later. Dr. Werthwein's going to dive into that. We've got a pretty fragmented system that we're going to do a lot to address. Workforce shortages, a lack of integration in a lot of ways. A couple that I'll point out around the integration of mental health and substance use treatment, as well as a lack of integration around behavioral health and physical health care. And then something that you hear over and over is just the stigma, not just the stigma of behavioral health conditions, but the stigma of seeking help for them. And that's just to name a few. I've got up there the links to where this information is. As I said, it's very well documented. So a needs assessment was conducted by HMA. And there are several documents related to that at that second link. And then the efforts of the Behavioral Health Task Force and the blueprint around behavioral health reform, that link is also provided there. Douglas County leaders have been really involved in these efforts. So a lot of thanks to Barbara Drake, who was part of the task force, the executive committee, and continues to be involved in the executive committee for behavioral health reform. Chief Duffy, who was involved in the behavioral health task force, and all of your commissioners are involved at the state level, providing leadership to the opioid settlement dollars that are coming. Commissioner Thomas and Commissioner Teal and Commissioner Layden providing a lot of leadership at the state level. And I know, HMA has been very involved in behavioral health efforts with the state. And I know the state's looking to Douglas County and has looked to Douglas County for your excellent work in behavioral health and the excellent work you do in community collaboration as a model. And forgive me for my sniffles. Let's go to the next slide. So, as I've said, mental disorders, poor mental health, along with substance use disorders, they play a role in poor physical health and chronic illness. Mental and substance use disorders, trauma, obesity, smoking, chronic disease, all of those things are linked. And although we don't commonly talk about them this way, many mental and substance use disorders are themselves chronic diseases. They're rooted in complex, interconnected, biological, social, and psychological risk factors. And to effectively address the challenges of behavioral health in our communities, we need cross-sector, multifaceted strategies that are coordinated, that are non-duplicative, that are mutually reinforcing, that are measured and improved upon, and that tap into the strengths and resources of partners that are coming together around a shared goal. That's what Douglas County's been doing for many years. That's what all communities should be doing around these issues. So that means, we have health systems that care about behavioral health, that are involved in trying to do something about behavioral health, justice systems, education systems, workplaces, CBOs, community-based organizations, social services, public health, and others have a stake in behavioral health outcomes. And there are many passionate people who want to make a difference along the continuum. So what do we do about that? Let's go to the next slide. So one framework that I like to use and promote a lot, it's not the only framework, but I think it's a good one, is collective impact. There's a lot to be learned from collective impact as a framework. It supports going beyond just coordinating activities or just collaboration. It goes beyond just sort of, coming to a meeting and sharing what your organization does or reporting out. It actually requires a little bit more than that. And you can see here on this slide, I won't read every single one, but sort of what's at the root of collective impact is that it's really structured. There's certain conditions that need to be met for it to be collective impact. And it involves a shared understanding about what the problem is that you're working on, that you're trying to do something about. There's shared agreement about how you're measuring your progress and accountability for that progress. Equity is really at the center of the work. And it really involves recruiting and co-creating with community members. And that's something that I've really seen in Douglas County with your DCMHI, is this cross-sector partnership and this co-creation of the work, of the activities, of your priorities. And that's critical to having collective impact. Let's go to the next slide. And so these are the 5 conditions for collective impact success. And again, as I mentioned, it's more than just collaboration. So you have that common agenda that you start with, right? It becomes your North Star. It is what you're moving towards. And it is your shared understanding of the problem and your common goal. You have a shared measurement, and it's not just measuring the outcome, it's measuring your progress along the way, and it's your shared accountability, how all the partners hold each other accountable for where you're headed and for the progress you're making. You have mutually reinforcing activities so that you're ensuring that what each partner is doing is not duplicating what you're doing, and that it reinforces what one another is doing, and that it best taps into the strengths and the resources that each partner brings to the table. You have continuous communication so that you're building trust, so that you're aware of what's happening and you're aware of what activities are being implemented. You're aware of how they're mutually reinforcing. That continuous communication is very important. And then perhaps most important is a backbone organization. In the case of Douglas County, that is the county. And man, they're doing an outstanding job just really making sure that things stay coordinated, organized, and moving forward. Let's go to the next slide. And so when you have that coming together, that strength of collaboration, that is centered around having collective impact, shared impact, you really move things from individual action, the success of one organization in the space of behavioral health, to really making significant system change and then ultimately population change. And that's something we're seeing in Colorado with the significant reform efforts that are happening right now. This is not just the success of CDHS or public health or the justice system or HICPUF. This is really going to be collective impact across the state. And we are going to see significant system change and ultimately population change. And that is something that you're also seeing in Douglas County. And so this movement towards more significant change. Let's move to the next slide. So I wanted to share with you just some examples of effective collaboration. And really show you both at a large scale, at a national scale, all the way down to a local level. So this first example here is the overdose response strategy. This is at a national level. This is an effort funded by the Office of National Drug Control Policy and the Centers for Disease Control and Prevention. It's a collaboration across public health and public safety, which are two entities that are very, very different, right? And they came together to address opioid overdose. And what they found is that law enforcement or public safety really understood that they weren't going to arrest their way out of it, out of this issue, and that they were feeling very frustrated about having to respond to arresting or to providing naloxone to reverse overdoses to the same people over and over. And really getting sort of compassion fatigue around that. And public health really understood that they weren't going to be able to implement effective harm reduction strategies or prevention strategies without engaging law enforcement. And so these two sectors came together in a highly collaborative effort to share data, to share insights, to really look at trends in overdoses in order to develop shared strategies for addressing them. So it's a great example. A link is provided there if you want to learn more about it. In Delaware, another great example of multi-sector teams and cross-sector sort of strategies. CRTs are community response teams. They came together originally to set up what's called points of distribution to distribute naloxone to reduce or to reverse overdoses, opioid overdoses. And they've now expanded their work to include all kinds of things, prevention activities, education campaigns. And it's a ground up, really localized effort that engaged businesses or engages businesses, nonprofits, the health system, law enforcement, government agencies, individuals with lived experience. So it's a beautiful example of all kinds of partners who come together and regularly work together around the opioid crisis in Delaware. And again, a link is provided there if you want to learn more. Next slide. And then another example, also in Delaware, funded by the state, it's called the Community Wellbeing Initiative. Again, another great example of lots of partners coming together to address a really difficult problem. So this one was addressing individuals who were struggling with substance use, but who didn't access traditional services or formal services, and who really needed all kinds of support around social, economic, and emotional kinds of needs in order to successfully address their substance use. And so what this group did is they put in place community well-being ambassadors. And these were individuals who lived in the community, who came from the community, who could reach out to these individuals who were struggling as ambassadors and connect them to services. And they really had that built-in trust and could break down those barriers that were related to stigma around the system. And that really came from this sort of ground up approach and having all these partners at the table. Next slide. And the final examples are from Colorado, because Colorado just grows great work and stuff here. The first one is the Colorado Consortium for Prescription Drug Abuse Prevention. That didn't start out as a collective impact initiative, but it has since been evaluated for that and found to be effective for that. And that is again a cross-sector, both public and private partners addressing prescription drug abuse and for opioid stimulants and sedatives, and bringing together lots of different partners across state agencies, academia, and others. And so you can see the description here, the different work groups that are involved in that. And that's really grown and done some great work. I forgot to include the link here, but you can find that information if you just Google Colorado Consortium. And then finally, last but certainly not least, is the DCMHI itself. HMA has been working with the DCMHI for about 3 years. And when we started and helped the DCMHI to create the blueprint that they are now working with, it was very clear to us that it was a beautiful example of collective impact and just a truly unique collaboration. So that unique community partnership is a great sort of moniker, because that is truly what it is. And really, you know, to have a successful collaboration, you have to have folks who come to the table and leave their egos at the door, leave their agendas at the door, in service of the greater community good. And that is what is happening with the DCMHI. It is really just a sense of commitment to the whole continuum of behavioral health and commitment to the whole person's health. And when folks come to that table, that is what their commitment is to. So with that, I'm going to turn it over to Laura, who's going to tell you more about the DCMHI and that collaboration. Thank you.
Thank you so much, Shannon. Hi, everyone. I hope I'm coming in clear. And if I'm not, I trust someone will pop into the screen and let me know that they can't hear me. Appreciative of your introduction to models on community collaboration and how they can affect real change in communities and impact health outcomes. So quick introduction from me. I'm Laura Cinconi. I coordinate the Douglas County Mental Health Initiative. I had intended to be present today. Certainly wish I could be there with all of you, but life happens. And I'm very appreciative of the team behind the scenes who made a quick switch to allow this virtual option to happen. So thank you. And let's hop in. I'm going to talk a little bit about our model in Douglas County. So quickly, a bit of history. The Douglas County Mental Health Initiative was launched 7 years ago in June 2014 with the support and leadership of our county commissioners and county staff, following and in response to a few serious tragic events that happened in and around Douglas County, which Commissioner Thomas spoke about this morning. And what was really hoped was that through coming together in partnership, we could improve the health outcomes of Douglas County residents by addressing unmet mental health needs, connecting people to services, expanding access to care, and preventing those who were in need of supports and services from falling through the cracks of the mental health system. So after gathering as many perspectives and partners as possible, the Mental Health Initiative began its collective journey to understand the challenges, understand the gaps, where there was duplication, but also where there were opportunities to collaborate and make a real difference. So in preparation for today, I've been reflecting on the conditions that allowed the Mental Health Initiative to flourish. And so for this part of the story, I'm drawing on the experience of my colleagues who've been in the initiative since its early days. And so even though this may seem small, the process mapping that happened at the beginning of the initiative had real impact in the success of the initiative long term. So as Shannon mentioned through her observations, partners came to this initiative with the primary goal of learning versus owning or defending the way that the system was or wasn't functioning. There was transparency, humbleness, openness, and a commitment to understanding the system as it was before making any effort at all to change it. We rely in the initiative on support from over 44 organizational members across 20 plus stakeholder sectors, which span health systems, the justice system, the education system, first responder agencies, payers, community-based organizations, social services, public health, and more. It's quite a diverse bunch of partners, but what we do have in common is an interest in improving mental health outcomes for Douglas County residents. And without a doubt, it is the representative partnership in the initiative that has been the glue for the past 7 years. So Shannon described just a couple of minutes ago, we also use a collective impact model in the mental health initiative. So when it comes to partnership, we think and believe that all voices matter and are certainly critical to ensure that our efforts are supportive of one another, both by reducing duplication, but also so that we are effectively leveraging the talents and strengths of each partner organization. We recognize that no single entity can do this work alone. So indeed, all of our programs and all of our strategies have multiple perspectives at the table, from the design phase all the way through implementation and evaluation. Since its beginnings, we have had a keen eye towards breaking down the silos of communication or those parts in the system that put up blocks on communication. So in that regard, we've had a very close and unique partnership with our county attorney's office. And many of our partner agencies have committed their own compliance officers to make sure we're constantly talking about ways that we can effectively share information and build a network system of care, which has a real impact on the quality of life of individuals in Douglas County. And ultimately, what we are looking for in the initiative are willing partnerships and getting to yes. A product of our blueprint for an integrated community-based mental health delivery system, which was created by the Mental Health Initiative. There's a link below this visual, and this is also on our webpage. It's very similar, or recognizes kind of similar aspects as the dual access model of mental health that Shannon presented, in that it recognizes that our health and well-being is flexible. On any given day, as humans, we change as our circumstances change. So naturally, our system of care, to be effective, needs to move along a continuum and be responsive to our needs. So our collective work is not just about crisis. It's not just about individuals living with mental illness or substance use disorder. We are also focused on the community-based work, the preventive health promotion activities. We care about primary care. These settings play a major role in identifying behavioral health needs through routine screening and can assist in connecting individuals to early intervention support. And we are focused on crisis, on acute care, and on specialty behavioral health supports and recovery. We operationalize our multifaceted, faceted coordinated strategies outlined in our blueprint through our governance structure, which you can see here. We're guided by a common vision, supported by the broad mental health initiative. Our strategy is guided by the steering committee, and our work groups are really where the rubber meets the road. And these align with priorities outlined in our blueprint, which are creating a network system of care, rebranding mental health and substance use, interventions to address gaps, and our steering committee has taken on the big heavy lifts of workforce and policy. So I wanted to share a couple of examples of how some of our core programs are creating system change through our model of collaboration and the initiative. And the first is the Community Response Team, or CRT program. The revolving door of crisis through the 911 and emergency medical system was a gap identified in our early process mapping. And from that, the CRT was born in 2017 as the first program launched by the initiative. To date, our teams have served over 4,000 individuals in Douglas County. They have diverted over 1,000 crisis encounters away from emergency departments in favor of direct placement to inpatient facilities or crisis stabilization units. Or many people are even able to remain in the community or at home with safety planning and follow-up. Jail has been avoided in over 500 cases, and collectively nearly 4,000 first responders have been relieved from the scene of a crisis and sent back into the community where they can protect the public's safety. And we estimate conservatively that the CRT program has avoided and cost $6.46 million over the last 4 years. And another example of how we believe the CRT is creating system change is a decrease in 72-hour mental health holds that we've seen through the sheriff's office. So as you can see, after years of steady increases in mental health holds, when the CRT launched in 2017, we started to see a decrease. And we're not aware of any changes to protocol, policy, practice, other than the implementation of the CRT at the time. And the decrease that we're seeing in 2020, we think is probably more likely tied to the pandemic. The average monthly M1 count for 2020 was around 45, and we're seeing so far in 2021 an average of 53. So it's coming back up a little bit, but still wanted to give this example because it has trended down since the CRT was launched in 2017. The CARE Compact, which launched as a pilot in December 2020, offers the next ring of support around the CRT program and serves vulnerable adults with co-occurring mental health needs, substance use disorders, intellectual and developmental disabilities, and safety net social determinant of health needs like food and shelter. This data is from a survey of case managers and care coordinators from our 10 partner agencies. So anyone that was involved in a CARE Compact team working with an individual was surveyed. And we were looking for input on whether the CARE Compact was reducing duplication of services, improving transitions between levels of care, improving access to appropriate services and levels of care, addressing gaps or barriers to treatment, and the ability of the CARE Compact to address social determinant of health needs. And we can see that in all cases, the majority of respondents believed that the CARE Compact had a positive impact on streamlining coordination of care. And to Shannon's point about shared measurement and accountability, this is the kind of data that we collect for our programs to make sure that we understand how they're running, but also know where we have room to grow. But so far, the CARE Compact has served over 20 individuals, and we are seeing positive impacts on quality of life. In addition to those two programs, our work groups have supported the Let's Talk Anti-Stigma campaign by sharing messages via social media. And we've localized the campaign through filmed PSAs with our Board of County Commissioners and with local youth, both in English and Spanish. And a working group of the initiative created a web-based app, which creates an access point for information, self-screeners, health assessments, and treatment and support services in mental health, substance use, intellectual and developmental disabilities, and general well-being. All of these resources are categorized by age group, and they're all age appropriate. And we are currently focused on a pilot with youth aged 13 to 17. So again, in reflecting on what I think makes us so unique in Douglas County, why our model works. These are a few things that come to mind for me. Timing. The foresight of county leaders to create the mental health initiative in 2014, and also the willingness of all of you as partners to jump on board, really positioned the county and the mental health initiative ahead of the curve. We have been prepared to respond to rising challenges and the needs of a rapidly growing county. This group launched one of the first co-responder programs in the state and has remained a model for co-responder programs that have come since. This group created a thorough blueprint outlining strategies to address gaps and now stands ready for the reform at the state level to pave the way for local solutions. Partners and governance. So yes, diverse, there are many of us, but again, we are all united around a common interest to improve health outcomes for Douglas County residents. Every single one of us, through both personal and professional experiences, have witnessed the gaps and challenges present in the behavioral health system today. And we care deeply about making a difference and making it work for people in Douglas County. Having a backbone, having dedicated staff to drive the work and maintain momentum is key. And our initiative's commitment to data collection and analysis and having those targeted work groups that really can dive into topics and projects, that is key to our success as a collaborative. We are action-oriented. Certainly, this group has been incredibly proactive over the years in identifying gaps and then doing something about it, actually turning that knowledge into action, launching programs, gathering data, making an effort to understand what we can do better. We are dedicated to programs that are impactful. And this impact we can see through our data. The things that we tackle are relevant, they make a real difference. And because this initiative has been so focused on collecting stories, collecting pieces of information, and sharing that with partners in the community, we can really tell the story of how this group is making a tangible difference. So really, to all of you, all the partners in the room, everyone joining via live stream, this is possible because of you. Very little of what I talked about today would have happened without your passion, your dedication, and your presence. So thank you seems like such a small thing to say, but just sending everyone abundant gratitude and thanks. This day is about you, and I hope that each of you enjoys the summit. So thank you all very much, and I will turn it back over to Commissioner Layden. Thank you.
Me to use this microphone. Hopefully this is the right one. Carrie, where are we at? Okay, good. Well, I wanted to thank Shannon and Laura. I mean, they're being incredibly humble, but that partnership with everybody in this room and in Douglas County has become not only a regional model, but a statewide model for the way to deliver mental health services. I'm really excited to share a special guest who's here with us from the state. But before I do, I wanted to provide a couple of introductory comments around behavioral health and part of the journey that the county has been on this last year. Like many of you, you're probably sitting here thinking, this is such a huge issue. I've been working on this issue. What can we do? What can I do in my role to do more? And I certainly, when I first began as a county commissioner 3 years ago, certainly was in that same mindset of there has to be something impactful and tangible for people to actually bridge that gap between the need for mental health services and actual services to address crisis. One of the initiatives I mentioned to our county manager, probably my first week in office, was the opportunity to potentially have a 3-digit mental health line in our county. And at that time, we had the text to tip campaign, Safe to Tell, which are absolutely fantastic. But oftentimes in my mind, I was thinking, is there a way for people to access mental health services immediately? We have 911 when there's an emergency, and we have phenomenal members of law enforcement that can get out in a crisis and address those issues. But mental health can also be a significant crisis. We all know that. How do we reach resources in those moments of true desperation? Fortunately, I was not the only one thinking about that, and a bipartisan group of legislators, one from Colorado and several in other states, brought forth legislation, federal legislation around the National Suicide Prevention Act. That was in October of 2019, and it was the 988 Suicide Prevention Line. That flew through Congress, and there's nothing better than a win-win that's bipartisan that everybody can support. So there were a couple of challenges associated with that legislation, but it did go through with some success. Once it did, it was up to the states to actually implement that three-digit line. So all 50 states had to address their own statewide legislation to make sure the 988 line was up and running. Now, one of the wonderful things about Colorado is we're one of only 2 states that already has the infrastructure for crisis services. We already have an 844 number it's through Rocky Mountain Crisis Partners, which is run by Bev Marquez, which is just absolutely phenomenal. But how many people in this room, you're all professionals, raise your hand if you can rattle off, a crisis line off the top of your head. Anybody? We got a couple here too. I'm hoping that everybody in this room will be able to remember 988, just like they've been able to remember 911. But this last year through Senate Bill 154, it was sponsored by Senator Simpson, Kolker, Representatives Cutter, and Soper. That passed through to allow for an enterprise fund in the state of Colorado. And our special guest today, I'm sure will share a little bit more about that, but I've been honored to serve on the State Planning Committee for 988. And today we have with us, we're very thankful to have with us a friend and colleague, Dr. Robert Werthwein, PhD. He's the director of the Office of Behavioral Health at Colorado Department of Human Services, and that's a position he's had since 2017. Today he's going to talk about the work of Colorado's Behavioral Health Task Force and behavioral health reform efforts in our state. He directs operations and administrative oversight of the public behavioral health system, including mental health and substance use community programs, as well as the operation of the Colorado Mental Health Institutes at Fort Logan and Pueblo. He leads in providing policy, performance management, fiscal and administrative tools, and oversight to a large group of mental health facilities, treatment centers, and clinics statewide. He's got a doctorate in clinical psychology from Howard University and a postdoctoral fellowship with the Harris Infant Mental Health Program at the University of Colorado. So please help me welcome Dr. Robert Werthwein.
Thank you. Thank you for the introduction. I'm going to move over here. Are these, it's going to cause feedback if I move over here? Anybody know?
I'll join you.
There we go. So thanks for the introduction. A little funny story. I may be overseeing the state behavioral health, but I cannot oversee my calendar really well. When this got updated, I forgot to change the address to Pace Center, and I showed up at the administrative building in Castle Rock this morning, even though I live right down the street. So I can manage the Office of Behavioral Health, but not my calendar. So my assistant always reminds me of that. This is what happens when I manage my own calendar. So thanks for the invite. I'm going to keep this somewhat casual and talk a little bit about where we're going as a state. There's been a lot of work, and I often tell Barbara Drake this, that we're doing a lot of work, but we actually do seem like we're a couple steps behind Douglas County often at the state level, where we're going with behavioral health. And I see Captain Duffy here, who's been integral in our behavioral health task force work, and Barbara Drake as well. Both were involved in sort of what's not working, what's working, and where we need to go in behavioral health in our state. I don't even know the date anymore, but Governor Polis essentially created the Behavioral Health Task Force to reform our behavioral health system. There are many things that work well with our behavioral health system, but there are many things that don't as well. So what do we need to do that's different? Well, for starters, we're ranked at the bottom of states in this country, which makes no sense to me, but we are ranked at the bottom of Mental Health America's rankings for behavioral health. And the way they rank it is how many people need behavioral health services and how many people are not getting behavioral health services. So part of that ranking is we actually do a pretty good job identifying people who need behavioral health services. We've not kept up with the amount of services needed to provide that. So 1 in 5 Coloradans need a behavioral health service. Think about that for a second. 1 in 5, how many people in this room? Right, 1 in 5. So I'm one of those 1 in 5. That's 1 million people in the state of Colorado. Our system is not built, it's not functioning to serve 1 million people. And what's happening is it's falling on the criminal justice system to serve many of those people. And you probably don't know, we're under a federal lawsuit as it is. We have a lot of people going to court because law enforcement will run into, and I don't need to tell law enforcement in here or the CRT team in here, but you run into the same people over and over, right? And then you get a little frustrated, like the community's like, well, you got to do something. You can't just leave them here because you're just going to be back later tonight. So every one of those people get picked up by law enforcement, now have to go through the court process. A third of those, almost a third, are misdemeanors. Public urination. I mean, they're sort of charges for the purpose of trying to get someone services, right? The rest of us would have got a ticket and told to go home, right? Individuals who need services are actually going into the jails, and then they're court ordered to the hospital for incompetent to proceed with trial. Basically, it's just a way to get services for a lot of these folks. It's not really about their charges. It's about they need services, they need care. So we're clogging up the criminal justice system, we're clogging up the court system with individuals who just need help. And I say that because it's unfortunate that as a state, that's sort of where we've landed. And we never intended that, right? I think everybody through the decades has been very well intended when it comes to behavioral health in Colorado, but it's sort of where we landed. So how do we untangle that is sort of the next step. So I'm big on, and if I say anything, I'm from Jersey, so I tend to use a little foul language every now and then. Forgive me if that happens, but I'll say this. I'm big on I got to clean our own house, and I was having a conversation with Bill from All Health yesterday, and we have a similar philosophy of we're not perfect. We're not perfect. It's important that we get we clean our own house up if we're going to ask for help and we're going to ask for to be trusted to do more. And I do have to commend All Health and under Bill's leadership over the last we came on just about the same time, about 4 years. It's a different organization today. And now I'm not blaming the old organization either. Not. It's a lot of pressure, right? It's a lot of pressure to be that organization that's supposed to serve your community with the resources you have when the ask is so much larger than the resources you have. What happens, though, is that all in the criminal justice system. So the delta, the difference, right? Everything that our behavioral health system can't serve all falls in the criminal justice system, which is a horrible, horrible way to go. We had 342 people today waiting in jail to go into the state hospital. That's the worst it's ever been. We were at 39 people the day before COVID hit. And now we're at 342. 2 people successfully committed suicide in jail. That's not okay with me. That gets me angry. It gets me angry, right? Because not only I'm actually legally responsible and liable, my attorneys, the AG's office will be freaking right now for me to say that in public. But it's the truth. So how do we fix this, right? So we got to get our own house in order, and I think it's what's really important about getting our own house in order. Let's see if I do this right. Let me click on it. There we go. I'm going to skip over this and show this. I'm the most anti-bureaucratic government guy you've ever met. I really am. It's why I love working in state government. There's nothing better than being like, oh, I got a pragmatic, realistic solution for this. Why are we doing it this way? It's actually makes me look a lot smarter than I am in my job, right? Because I just go in and I'm like, well, why? Like, what's pragmatic about this, right? This is what our system looks like today. It's not good for us as a state. It's not good for you as a community. It's not good for providers. When providers have to do all these lines, comes an administrative burden with every single line, every single one of those lines. So what you're seeing here is the various state governments. You have courts up there, and then you have CDE out here, which are two entities that are not in the governor's purview, but are important. Probation is one of our largest behavioral health providers in the state. You have your crisis system, you have your substance use, you have your Medicaid, which is the RAY. You got community mental health centers who contract directly with state agencies, contract through the RAYs. You got county government and schools doing their own grants and efforts to meet constituent needs. You got federally qualified centers. You got specialty providers for substance use. And you got private providers over there. This doesn't work. And we hear from, I'm sort of preaching to the choir here. We hear from all our consumers the same thing. They feel this. They feel this. So we're failing them. You know, during the behavioral health task force, we had a realistic, we had a consumer story from a mom that exemplified this. She had a child, they're in Eagle County, had a child who had needs, wasn't getting met, got worse, eventually needed to be put in inpatient at Children's Hospital. Needed to be discharged. Denver, Eagle, not close to each other. Had to start all over with a new provider in their community. And then every time they had to step down, they had to start all over and all over. And then there was a disconnect with the school. That young person took their own life. They felt helpless starting over and over and over and over and over. They didn't feel like they were going to get anywhere. So how do we fix this? We believe the first step is the Behavioral Health Administration in the state of Colorado. That is the proposal that's on the table today. There will be a bill, and there will coming this session. There was a bill last session to create it. Now it's getting down to the details of what it looks like. So some things I'm going to share today. I'm not even sure I'm supposed to share publicly yet, but we're just going to talk a little bit about the BHA. I've talked to my team internally about the efforts we're going to. The Office of Behavioral Health right now that I oversee, we have community behavioral health, which works with other community providers in the community system in counties. We have 2 state hospitals. And then we have the Division of Forensics. That's we're responsible for not guilty by reason of insanity and those that are in courts, that are held up in courts with mental health needs, and where we're at with that. So what we think is we do a really, really bad job, each one of these agencies, trying to solve behavioral health by themselves. Not only do we really do a really bad job between each other, we do a really bad job working with our local communities on solutions. So we're all trying to find our own solutions. That's not good. That's not a good use of taxpayer dollars or efficiency of government. We're each trying to do the same thing. We're competing with each other internally for providers. In some cases, driving up rates and losing staff. It's still true. We're losing staff between each other because we're competing with each other versus saying, how do we solve this together? So what is the Behavioral Health Administration? It's not going to be the agency that does everything. It's going to be the agency that coordinates everything. The work across agencies, create shared goals, improving collaboration, driving accountability and transparency. This work comes up over and over and over again. I'm going to laugh because I had a meeting with my one of my attorneys yesterday about privilege and about accountability, and I'm like, well, let's talk about transparency, and the lawyer's like, no, don't share any information, it's privileged. I said, but if we're screwing up, don't we want to be transparent about it? And she said, no, we're gonna get sued. And I'm like, well, if we're screwing up, should we get sued? They hate me. They really do. And it had to do with the hospital, and it had to do with our staff. You know, we have patients who make allegations all the time, and there's an investigation that goes into it that the staff don't get to see the report or the investigation findings, but then they could be held responsible from a personnel standpoint. And I'm like, well, that doesn't seem really fair to our staff. That's a horrible culture. And she goes, but you don't want to share, you're going to get sued. I'm like, well, if you did something wrong, we get sued. So be it. So that got pushed up and up at the AG's office about, we can't let Robert do this. I'm like, why not? What are we hiding, right? Again, bureaucracy. I'm the most anti-bureaucratic person you want. The commissioner's shaking his head, yes, but if any of you did that and the county got sued, he'd feel very differently. Maybe. I know you do. I'm just joking. I'm joking. So in doing so, the transparency thing's really, really important. We're not fooling anybody. It's not working. And when it's not working, it's clear it's not working. We're not fooling anybody. So why not just be really open about it? And why not share the accountability? Right? It's no single person is sitting there saying behavioral health's not important. Why not share the accountability? The question is, how do we do that? How do we do that going forward? So transparency and accountable system in place is really, really important. I'm really big on data. I'm really big on data being on websites, not government-designed websites, privately designed websites, which function a lot better. We did, when I was over child welfare, we did the same thing. We put all the county data, and the counties were not thrilled, but we put all the child welfare data on the website, and they're like, oh man, the reporters are gonna come, they're gonna get all worked up. What happened was the reporters no longer had a gotcha moment. So the media requests actually went down. They actually were like, well, how come you didn't? I'm like, well, we told you about this website. It's been there. The data's right there. So there's no gotcha, which to a lot of the reporters is like, oh, this is boring. I'm not going to go down this. We actually saw media go down. So I'm hoping behavioral health the same way, because if you've been reading the Colorado Sun, the Gazette, the Chieftain, 9 News, or whatever news channel you want to put on right now, we are everywhere with behavioral health. We're everywhere where we're failing. But nobody here is probably surprised. I'm not surprised. When COVID hit, I was just like, oh, this is just going to put a magnifying glass on what's not working. And that's what we're seeing. The BHA will provide an opportunity to streamline our overall system. So we need a state strategic plan. And there's something we're working on now is not just a state strategic plan, but we're investing our dollars at the state to have CHI go around to local communities regionally. And if we can get a little more funding, we'll do it by county as well, to say, here's the complete continuum. For every 100,000 people, you should have X outpatient, Y inpatient, Z step down, this much invested into prevention. And we should go in every community with this sort of template. And then we could say, where you're green, yellow, or red on this continuum. Because while Douglas was one of the early ones to invest in behavioral health as a county, more counties are coming on board with mill levies and other ways to invest, using ARPA dollars to invest into behavioral health, the opioid settlement. My one fear is that we're all going in different directions, and we're not building a sustainable system, right? So the BHA is gonna help with that. And we would like to create this template. We're not gonna tell you how to do your community response. We'll say community response is an effective, needed part of the continuum. Do you have the right level of resources? If you're going to invest X dollars, here's a map of how things are going. So that's where we want to go with that, so that we're sort of investing together. And it's not all talk either. When the crisis system was first started, and it was created in a rush, after the shooting in Aurora, the current crisis system was put in place after that. The contract went out to providers directly. And there's some things that worked really well with that. There's some things that didn't. It got really confusing at times. What was crisis related, what was other business related, other service related from other funding sources. And Douglas County, and I'm not saying this just because I'm here, was one of the key catalysts, and Summit County as well, in changing just contracting with providers. Because then you all were creating the CRT system, and you were creating your own mobile response, but yet the state was funding a different crisis response system, and it just didn't make sense to me. So one of the first things we did was, after talking with several counties, is we decided to create sort of an administrative service organization that would oversee a network of providers and communities, so we could invest where the counties were already investing, if they were investing. If they weren't investing, then we could create that and start new with that. We ended up using almost all the same providers, by the way. It's just a different structure. It's a different control as well. it is really, and I think partially is because I started an Office of Children, Youth, and Families before my current job, and worked very close with counties, got yelled at by counties and child, but we had a really good relationship. And I really do think in Colorado, the only way it's going to work, the BHA, is if we built in the infrastructure, how we're going to approach this together. So, this is stuff about payments across systems. I'm not going to really go into that. So this is the stuff that's not fully public yet, but it's no surprise, right? So we have our staff, our commissioner that the governor is going to pick. That's going to be a cabinet member. So there's authority, there's influence, there's ability to pull the trigger. Right now, if you got a complaint about behavioral health, whether you're a consumer or county, whoever you are, you got to figure out what your payment source is before we can help you. You got to figure out whether it's healthcare policy and finance, if it's OBH, if it's child welfare, if it's CDPHE. You got to figure out your payment source, or I can't help you. Right? That's going to change, right? Because then it goes up to the executive director, and the executive director to the governor's office, and then they all talk about, well, which one of it is it? Who is it among us? In reality, it's all of us. So there's no ultimate person. And I like to tell legislators, by creating a commissioner, you got someone to yell at. You know who you're yelling at. You know whose phone number you got to keep to make that phone call and say WTF. But we can't let we can't let the departments off the hook either. Right? Medicaid's still got to be responsible. They got to own some of the solution. I'll tell you that wasn't always the case. It's been the case with the creation of task force, now the executive director of Medicaid, who cares deeply about behavioral health, but you would have never known it before. But now that she's involved in this group that's supposed to come up with solutions, it's coming across. And then solutions are happening. We're getting the right rates for behavioral health care, right? In child welfare and other areas, we have kids with very complex needs. We've been placing them in residential settings that are not equipped to meet their needs. So no wonder they're failing out. No wonder they're running. Because the rates that we're being paid were not enough to have the right staff, the right clinicians. So they fixed those rates. That matters. That really does matter. And I'm not, money is the last question I always ask. But money's right next to the word sustainability, right? I mean, it's only sustainable if you can fund it. I mean, I don't think anybody here is working for free. So that has to be that sustainability part. The last part's really important. We tend to do work groups and advisory councils as an ad hoc thing a lot. We need consumer input. We need county input. Let's put a group together and ask them what their thoughts are. We got to build it as part of the infrastructure. We need a continuous quality improvement feedback loop by region, by county, what's working, what's not working. So we know if what we're investing in is working and not working. And we got to take our pride and throw it out the window. It's the hardest part. I gave a speech at the National Council of Addiction Disorders, and I'm glad that the governor's office wasn't there because I talked about we don't like each other. Providers in state, we don't like each other. We do when we have coffee or whatever, and we get together and talk, but day to day, we're immediately at this distrust point and this defensive point, but we're both well-intended, and the problem is the feedback loop is really broken, and that trust is broken. We need that continuous feedback so that we're making the right changes, but we gotta both let our pride go. The thing, and I bring this up because I have this with my team all the time, my staff, it can be hard because you're busting your ass, you're working a lot, state employees don't make a ton of money. Every media thing is your fault. So then you start getting defensive and you start being like, I'm doing everything I can. It's not me, it's you, right? That's our human nature defensive sort of, I'm in a corner, I'm now in attack mode. So my pride is getting in the way. Not in a negative way, we all have pride, right? It's what else do you want me to do? I've been feeling like that the last couple weeks. What else am I supposed to do? I'm working 12-hour days. I'm doing what I can. And I always have to catch myself where I'm on the defensive to not go the other way and say, okay, you know what, I know I'm exhausted, but I'm still doing X, Y, and Z. I could do X, Y, and Z better, right? And letting it go. I have a really hard time with that when they're my ideas. You know, I have something that's the idea and I'm really pushing it hard. And one of those was care coordination. So about a year and a half ago, I really pushed hard on a statewide, overseeing care coordination infrastructure system. And you know, we got a lot of feedback from people. I got 5 minutes. All right, cool. We got a lot of feedback from people that it's not working, and we already do this in the community and things like that. And I had to let it go. It was hard for me. I had to let it go because I designed the whole thing. I'm sitting up at night, like even came up with a logo, all this stuff, right? I was really passionate about it, but I had to let it go. And now what we're doing today is we're going to invest in the technological infrastructure for care coordination and only provide care coordination where the person doesn't have it available to them, right? That's the goal now. That's where we shifted. Creating a gateway of information for consumers by community. I mean, Google does this with restaurants. That's my end goal, right? Is have a Google Maps, but a behavioral health maps, right? Same thing. Outpatient therapy, click it in, zip code, who's available, and consumer input. You ever use Yelp for restaurants? Almost all their information comes from people that goes to the restaurant. We should be secure enough and comfortable enough to say, why can't consumers put information so other consumers know their point of view? It's a gamble, because I'll tell you, if I'm feeling depressed, I think everybody sucks. And I go on Yelp, and I put, you suck. Right? So probably a giant disclaimer on there or something, right? But it's important. You know what's the most important thing of that is this provider's in my network. I call, they're not taking clients, FYI. They're not taking new clients. This is like the $1 million question we can never solve is, and everybody's like, it's too hard. And then somebody told me this, one of the other executive directors, I'm not gonna mention it, said, don't take that problem on. You think nobody's ever been able to solve it. Don't take it on about the whole list of providers that take certain payment sources and they say they're taking new clients and you call and they're not. Don't take it on. The private sector couldn't solve it. You can't solve it. I said, well, consumers can. Right? So this is the kind of philosophy that we're really shifting to talk about a data source that exists that we can use, right? And you can control some of the narrative. I'm not saying Yelp like open-ended comments because that will not go well. But you can put, click this button saying provider says they're taking new clients, but they're not, and then give the provider a chance to respond, right? So since I'm running out of time and I could talk forever about this stuff, I don't think I have other slides that I want to touch on because I want to make sure I answer questions. Yeah. The BHA will start July 1st, 2022. It's not going to be complete July 1st, 2022. It's sort of phase one of multi-phase approach. So that's where we're at. We're really, how do we get to a continuous quality improvement process where the counties are feeding up information, we're investing in similar things, where both sides are happy with what they're investing in, and how are we all accountable at different layers? So I brought up the crisis system earlier because, and I think I got on a little tangent and went off, but I'll go back to that. When we created the ASOs, there were some people that were not happy, you know. And the reality was, though, we were taking the information from the county and say, I don't want to invest, and Douglas County was a perfect example. I did not want to invest in a crisis mobile if there was already a mobile team available. How do we invest in things that are already working? And I think that's where the BHA has to go. We may disagree. We're going to disagree on what those investments are. But at least we have to sit down and have that conversation. I find that when we do disagree, we're not that far off. I had a county that we just had this with the commissioners had to get involved because the sheriff and I get a little heated about mobile response, and they wanted to do it, and they wanted law enforcement to go to every single mobile response, and that's fine for co-responder, but for they wanted to be the crisis provider as well. And if you're going to be the crisis provider, you have to give the community the option between law enforcement and non-law enforcement. It's also not a good resource of law enforcement. So we really disagreed because he had in his head a certain program, a certain idea he did not want to let go of, and I did not want to let go of. The community needs to have the options of non-law enforcement response. If you're going to be co-responder plus the crisis response system, you have to do those things. It found out we weren't that far apart, and we just needed a conversation. So because all of our things were through email, so we just needed a conversation. we both ended up getting what we needed at the end. And ultimately, that's typically what it is. It's finding that time and space to do that. And that's what the BHA is really. So one of the benefits of the BHA is they're no longer going to see the state hospitals, because those are fires that we like sucks all my time every day. So really splitting the work up so the BHA commissioner has room and time to have those conversations and investments.
So I think you can probably see why we're such huge fans of Dr. Robert Werthwein. That's a big job, being the director of the Office of Behavioral Health. And in high school, I was voted most likely to be a college professor, and I really believe there's nothing worse than being lectured at. And I know Robert is very big on transparency and accountability, so I would love to open it up for questions. At this point, we have about 5 minutes of questions, and then we'll have a little bit of a wellness break. Is that okay with you? All right, sounds good. So I can run out into the audience with the mic. But what questions do we have for Dr. Werthwein?
You can't have none, because the group that has none is the group that's like emailing behind my back.
I know.
Curtis Hannock, Douglas County Healthy Youth Coalition. I think you can hear me. Just got a question. As our single state authority, according to SAMHSA, I spoke with our project officer, and he had let us know a few weeks ago that there is a large amount of money that's coming down to your office that's going out for primary prevention. And our coalition members want to know where that's at. And we can, according to what we've heard, that it could only go to existing programs or existing grantees. So, our kids, our families are struggling right now. And we're 2,000 to 10,000, depending on who you ask, clinicians short. We can't fill positions to take on counselor and therapist positions in our schools. What are we doing on the primary prevention area where least cost in the upstream? So where's this happening? Where's the money? Because we need it.
Yeah, so we did receive a one-time increase from block grants. It is going to the current prevention providers that are a part of the block grant. And I will actually follow up. I mean, it's not something I've been keeping close tabs on.
Current OBH grantees, because you're our single state authority, it should be all grantees in the state, right?
It's current programs that are being run, expanding their access. So that is the goal, because the time to spend the money isn't long, and the time to get the money out the door. So if you've ever worked with the state, for us to send it out to new people would be a 6 to 8 month wait to get that money out the door, because that's what procurement takes. And honestly, things are moving slow. We received, getting $500 million money is great. Being able to get it out the door with no new resources doesn't work very well, honestly. And we have a 25% vacancy as well, like many people do across the board. So unfortunately, it's going slow, and I hate that it's going slow. When you talk about money with the state, it is extremely bureaucratic. There's not, unless it's in law where it waives that we could just hand money out, it has to be either going to an amendment to an existing contract, or you have to build a whole procurement process. So that's where we're at right now. So there are several programs, and I can't list all of them off the top of my head, under the prevention grant. Now, one thing is going to change with the block grants is a permanent carve-out. So these are one-time funds, but a permanent carve-out to the block grant for prevention, which exists already, but expanding some of that prevention permanent carve-out, particularly around recovery services, and having a carve-out there, because that's not a carve-out right now. So those are some of the things that they're looking at as well. So,
Good question. Thank you for that answer. Other questions for Dr. Werthwein? Here we go. Andres, I knew you'd have a question. Here we go.
Hi, I'm Andres. I'm from Senator Hickenlooper's office. The senator sits on the health committee, and so then I'm here to understand what type of engagement would you most appreciate from the federal government? What would be your dream scenario, your home run, so I can get to work on making that happen?
I have a big list, just like the counties have a big list for me. I have a big list for. One of them was achieved that we could do more on, which is the DEA. The DEA oversees a lot of treatment routes. Methadone specifically is one thing that they oversee. And we have mobile units in rural parts of the state providing medication-assisted treatment, which is an extremely effective method, but we were not allowed to use methadone. And we kept complaining. I actually think your office helped as well on sort of saying to the DEA, like, come on, like, this is antiquated laws, and we need to update it. The other is, every time we get a complaint about all the data collection, I'd say about 80% of data collection is coming from above federal too. We're doing this process right now in OBH, and I'm meeting with my team next week to talk about, do we need, what are we collecting? Are we legally required to collect it? And if we collect it, what are we actually using? I guarantee is like probably like half of the stuff we ask for we're actually using. Same thing probably should be applied above. There's got to be a certain level of trust as we go down, and this is where it all comes from, right? Somebody somewhere misused, this is how government works, right? Somebody somewhere misused a funding source, and now everybody's got to put data in. Everybody's got to go, every minutia needs to be recorded because it hit a headline somewhere and didn't look good for somebody with influence. So the data collection is extremely heavy, and you can hear, providers will tell you all the time, their clinicians spend half their time doing data instead of seeing more clients. It's a workforce solution. We have a workforce issue. One of the workforce solutions is give your current workforce more capacity to see clients, and reducing administrative burden is one of the key and easiest solutions to that.
Well, I'd be remiss. I mean, I sit on the State Opioid Settlement Committee with Attorney General Weiser, and that's coming down to, Douglas County will be its own region, $4.9 million for opioid settlement. I think the best thing that the federal government can do, and correct me if I'm wrong, would be to allow these regions to do what they do best. I think government's best that's closest to the people, and I know at least in Douglas County, we feel really confident about what we can do for MAT treatment and opioid settlements. Let's do one last question, and then we'll move to a little wellness break. One last question. Councilwoman Hefta. Good question from Parker. Here we go.
So thank you so much, and I appreciate the fact that you're from New Jersey, by the way, so am I. So under this new system, initially you said you'll be focusing on the partners that are already in existence. What about bringing on new partners after that under your system? Will there be a process, a credentialing certification process to ensure that the partners you have are indeed performing the work and you're cutting the funds to those partners?
Yeah, so, there are a couple of things in that question. One, do we have enough money in the system? My governor still comes with my paycheck, so I'm not going to answer whether we have enough money and we need more money. But the other to that is credentialing, which will be a huge part of, and then the Medicaid system is going to rely really heavily on the BHA to help with that process. And then Senate Bill 19222, it was created, and it basically said, how are you going to build a more robust network of providers? We need the providers we have, and we need to invest in the providers we have. We just can't be close to the idea that we can about expanding that as well. We also need to pay the right way our current providers. Right now, we do this rate thing, and it doesn't really work because we really need to do like a bundled rate, like for somebody who's homeless and mental health and this and that, right? Putting a sort of a higher rate that's bundled together for certain providers who are equipped to do that, to get that rate. And then we need to look at our cost control. So the rates that are set right now are basically cost reimbursements for the most part. A company comes in and establishes cost. I say this all the time, but there's no expectation of cost control, right? So this new way will, I think, will be a little more balanced in that sense that there's a little more cost control as well. So,
Thanks for that question. How about a big round of applause for Dr. Robert Werthwein? Robert, thank you for being with us. Thanks a lot. All right, well, let's stretch, take a 10-minute wellness break. There is a mental health art display out in the hallway if you'd like to take a peek, and then come back and join us in about 10 minutes.
Hey, I'm George.
Nice to meet you, George. Ben.
Ben, excuse me.
Yeah, no problem.
Pardon me. I even have notes that say that, and I still got it on the computer.
Hi, I'm Crystal. How are
Crystal,
you? Nice to meet
wonderful.
you. Hi, my name is Carol. Lisa Carol.
Wonderful to meet you. I'm going to go ahead and get everybody back to order.
I'll sit here since you're going first. Does that sound okay? Yes,
Okay, everybody. If I could ask everybody to please return to your seats. Don't worry, we'll lock the doors after this session, so the person you're talking to, that you want to keep talking to, won't be able to leave. It'll be great. Well, everyone, I'm George Teal. I'm the final member of your 3 people who are your Douglas County Commissioners. I did not touch that laptop, I guarantee it. I know what I worked in IT for 23 years, and I did not touch that. I did not make that happen. Our next segment that we'd like to bring to you today is suicide prevention, a focus on veterans' mental health. And so to start us off, can I ask every veteran of the United States military in the room to please stand? I know I was standing, but I get to stand too. I too am a veteran of the United States Army, serving from 1988 through 1997. I don't know about you guys, but I still haven't gotten used to referring back to my early years as, the 20th century and using dates from the 1900s. I did notice that it looks like Councilmember Hefta snuck out on us. I hope she's coming back because her other title is Colonel Hefta of the United States Army's Judge Advocate General Corps. And Dave, you reached colonel rank, if I heard properly. No? What rank? Major. That's an almost colonel. That's fine. But Major Maxwell in combat arms branch, artillery. I started out in the United States military in 1988 in Fort Benning, Georgia, as an 11 Bravo rifleman, and then. When I realized, digging ditches and digging holes really isn't the way I wanted to spend my life, the Army was very generous with your tax dollars and provided for my education at the University of Northern Colorado, and I took a commission as a second lieutenant of the infantry. When we talk about mental health and veterans, the first thing I want to introduce to you is the idea of scratch out health and put the word injury in its place. When we went through Army basic training and we received first aid training, and I'm talking first aid on the battlefield, first thing we're taught to say is, it's gonna be okay. You're gonna be okay. I'm gonna help you, buddy. And then you perform the tasks required to stop a arterial bleed, to take care of a sucking chest wound, and other life-threatening injuries that we all do see on the modern battlefield. You're gonna be okay. We are prepared in the United States military for that injury to the body, knowing it's not it's not if, it is when it will occur. When we put it into the context of mental health, I'd like you to think in terms of veterans as it's not so much mental illness, but it is a mental injury. Indeed, military training is inherently injurious to the American mind. A perusal of the lexicon of the English language reveals many wonderful works of literature, some fiction, some nonfiction, names like Vonnegut, Mailer, Heller, Sledge, who tell the story of the mental injuries incurred by Americans on the battlefields of the last century. That's okay, it's going to be okay. But as an American growing up in Greeley, Colorado, I can assure you I had no teacher. State Treasurer Dave Young was my 8th grade math teacher. He did not teach me the phrase, blood makes the grass grow. Hunting with my father, my uncles, our friends of our family, shooting geese around Empire, hunting elk up near the Red Feather Lakes area around Rocky Mountain National Park. My father, a Vietnam veteran, did not teach me the running song that has the phrase, napalm sticks to kids. But this was the culture I immersed myself in when I made that step to volunteer to be a rifleman of the United States Army. It was that military training that for many years, it hardened my heart. It calloused my outlook. It replaced compassion with pride and unit. It replaced fellowship for much of my fellow man in the world with that extreme team orientation to where I was going to live and die for my buddies. I am not alone. I am not emblematic. This is the experience we ask our young people to take on with military service. And despite the critics of our culture who point to the violence in our culture, there is no baby boy, no baby girl born in America that was born and raised to be a killer on the modern battlefield. So what does that have an effect? Does that mean every veteran is inherently injured, inherently flawed? Have we ruined 1%, the 1% of our society that comes forward for military service? I like to think of the stories of our pro athletes. If you have the good fortune, like I've had, to speak to some of our pro athletes, names like John Elway, Peyton Manning, Mark Schlereth, one of our neighbors, still active in the Denver area. You know, they'll tell you, they've been retired from football for years. They're doing other things. They're sportscasters, they're celebrities. But yeah, there are still days that you wake up in the morning, you walk across the room out of bed, and something hurts. Tom Brady, I think, is famous, besides his exploits on the field, but he's famous for the personal disciplines he undertakes to stay healthy and to stay uninjured in what is otherwise a very violent sport of football. You learn to work with it. You cope. You get on with life. It'll be okay. That's the lesson we learn from our professional athletes. And quite frankly, from my personal experience after I left active service in the military, that was what I did. And I will tell you right now, I never had the experience of the modern battlefield. I am not a combat veteran. 10 years of my life was devoted to horrible days like that. But it was an experience that I got to sidestep thanks to the forces of history. We are ending a 20-year period where our youth have not been blessed with that benefit. We're ending a 20-year period where our youth have had to go out on the modern battlefield in the service of us. So when we talk about mental health for veterans, we must understand there are our brothers and sisters who have those mental injuries that are debilitating, that are in need of care. And then there are many who, their scars There's a part of their mind that's like the bum knee that hurts when they wake up in the morning and they walk from the bedroom to the bathroom. You deal with it, you cope with it. Sometimes all you need is a little TLC and focus to help heal, to help move through, to help cope. Because we are over 250 years into this noble experiment called America. Over those 250 years, we have fought wars that threatened what we have today. But it was okay. We are going to be okay. With that said, now that you've heard from the dumb infantryman, I would very much like to introduce your panel. All right, Doc. Doc, I'm probably gonna, you said your name twice to me. I'm still probably gonna mangle it. I apologize in advance. Dr. Brittany Mascaro is a clinical psychologist and local recovery coordinator for Southern Colorado with the Eastern Colorado Healthcare System. She earned her doctorate in clinical psychology in 2012 and has been working with veterans in the VA system since January 2014. She has a passion for helping veterans living with serious mental illness identify and reach with mental health recovery goals. Dr. Mascaro, I'm going to get that right one of these days, I promise, Doc. She joined the team in Colorado Springs as the local recovery coordinator in May 2020. A local recovery coordinator is a VA facility champion to provide education, consultation, and support to help create system change from a medical model of care towards a veteran-centered and recovery-oriented model of care. The Good Doctor is committed to supporting our veterans' communities, strives to promote activities that remove barriers and stigma associated with mental injury, and ensures that veterans have access to the rehabilitation and recovery services needed to attain their personal mental health recovery goals. Outside of work, why, she's a mom to 2 active little ones, wife to an Army veteran, and enjoys finding new areas to explore with her family. Please give her a warm welcome. Ben Kremer is a licensed clinical social worker and is a suicide prevention coordinator for the Eastern Colorado Healthcare System. Ben has worked in suicide prevention program for 3 years and is the current acting manager. Prior to that, Ben worked in outpatient mental health as a psychotherapist and case manager for 4 years. So I confess to you the foolishness of my youth that caused me to actually volunteer to be an enlisted soldier, a 11 Bravo infantryman. And so our next panelist, Crystal Tabor, she has a special place in my heart because she had the job that is special to every single infantryman on this planet, quite frankly. She's a U.S. Army veteran who served as a combat medic and now serves as a lead peer support specialist for the Eastern Colorado Veterans Healthcare System, providing direct care to veterans being served by the Suicide Prevention Program at ECVHCS. Like all peers, Crystal has lived experience in the area of personal mental health recovery and serves our veterans with similar challenges. Crystal uses her recovery story involving her own personal challenges with suicide ideation, as well as experiences with suicide, losses of close friends, and family. Okay, I touched the laptop on that one. She does this, and it fuels her passion for recovery and suicide prevention. Like I say, please welcome Ben and Crystal as well. So with that said, instead of a bloviating politician up here taking up your time, I turn it to our very esteemed panel today to take over.
Thank you.
see if I can nail the volume here. Does that sound good?
And by the way, guys, you can also make use of the microphone right there if you need to.
Thank you.
So remain seated if more comfortable.
Yeah, thank you. Yeah, that was maybe the best intro I've ever gotten before talking, so I would not mind just staying put and let him continue to talk. That was pretty solid intro there. So yeah, my name again is Ben Kramer. I'm the suicide prevention coordinator for one of them for Eastern Colorado, and we're going to kind of talk about suicide as a whole problem, and I'm going to touch on a lot of different statistics. So of course, I don't think anyone doubts that it's an issue for veterans and our general population, but sometimes it's pretty important to kind of know some of these details to just help really conceptualize what we're all dealing with before I'll hand it off to my coworkers here. So without further ado, I'm gonna give you a snapshot of risk. So suicide is the 10th leading cause of death in the United States, and coincidentally, it's also the 10th leading cause of death in Colorado. And also, every stat I'm going to share is tragic in its own right, but as you can kind of see, it's also the second leading cause of death in the world for 15 to 24-year-olds. So it clearly is a problem that is starting earlier and earlier that has to be addressed. So a few ways of looking at that is that, nearly 1 million people make an attempt every year, and that can kind of be broken down into 1 in 35 seconds, totaling more than 45,000 U.S. deaths from suicide each year. Breaking that down, right, in the time that we're talking, right, every 12.3 minutes, someone actually dies by suicide. The more we can learn about the who, what, where, when, and how, the more targeted interventions we can kind of create from a population perspective and, of course, from individual perspectives. So one example of that kind of identifying feature is that we do know that there's at least one gender disparity, which is women attempt suicide 3 times more often than men. And then on the flip side, men actually die by suicide 4 times more often than women. So clearly, there's always going to be different groups that we might potentially have different interventions or different strategies because, people are individual and people attempt suicide for individual reasons, but we also can use big picture data to really help understand what's going on. So data keeps coming in. It's usually a few years behind because it's hard to collect this type of data from the multiple sources. But you can see here in the top, right, that the rate of suicide was 2.2 times higher among female veterans compared to their non-veteran adult women. So what that tells us is that that's a pretty big difference, right, between women, veterans, and non-veterans. And then when you switch over to the males, it's actually only 1.3 times higher among male veterans. So that tells us that males are more similar kind of regardless of their veteran status, which either way points to knowing that, suicide prevention policies and strategies need to be applicable to everybody, of course, besides veterans. 2 groups that are kind of highlighted note are the males 18 to 34, as we were just touching upon with the Afghanistan situation, the last 20 years of combat experience. This group has the highest rate of suicide. So they are definitely, right, they get discharged, and we have to really get our hands on them as quickly as possible to make sure that they get the support that they need. The first year and first 3 years are a higher rate or a higher risk period for veterans transitioning because of readjustment and any other sort of common sense idea you could think about just going from one type of environment to a new environment. And then the other block that's really a concern are the 55 and older males, because that group is just so large that there's just more of them than everybody else. And of course, more population, more everything, the numbers tend to increase by that alone. So bottom line is about 69% of all veteran deaths result from firearm injury. So with this slide is relatively new in terms of data, so I was able to get this. So the main takeaway is here that sometimes we divide the United States into sections, and so obviously Colorado is in the western section, as you can see for the blue. The two main highlights this slide kind of represents is that suicide rates in Colorado are significantly higher than the national suicide rate. So it means that we have our work cut out for us here, especially because it's just higher. the numbers are higher for us. And of course, if it's higher compared to the national veteran suicide rate, it's also significantly higher than the national general suicide rate. So you can just see here that for 2018, there was about 173 total suicide deaths for veterans. And then I thought I would kind of connect that dot with kind of the United States. So you can obviously see the different color codings, and it kind of goes from white to blue to dark. You can see that the western half is darker and bluer than the eastern half. Of course, who knows exactly why that is. And fortunately, Colorado is not as bad as it could be, as you see Wyoming and some of those other darker blue states. But the bottom line is it's a problem everywhere, and it's especially a problem here on the west side of the United States. So, of course, right, as we're going to talk about, like what the VA has to offer and, what do we do about this, it's kind of good to know, right, because the VA is the healthcare system for veterans, but veterans can, of course, get care outside of the VA. So you can kind of see here that roughly 50% of veterans do not use their VA benefits or the healthcare system. And then on the right side, you kind of see that veterans who use at least one VA benefit or healthcare service are the other half, but only about 30% of that half use all of the available resources. So the goal is, you can see at the bottom, there's not enough space for every veteran to come to the VA or all the VAs. The bigger point is that we need the communities, no matter if it's VA care or community care or whatever type of care, we just need to make sure they're getting the care that they need. You might have heard different numbers around what has been the number of veteran suicides per death or deaths per day. The true number at the moment is 17 deaths a day. And you can see here that 11 out of 17 veterans, they're not enrolled in our healthcare system. So that's why suicide prevention has kind of its internal parts about what we can do for the veterans who we actually have our hands on. And then we have a whole nother section about how do we support those other 11 veterans who we don't have our hands on. So this is pulled from actually the Colorado website, that's a Colorado State website. You can basically track up till 2018 the suicide death rates per counties. So this you can kind of see that the bluer counties are 9 out of 10 of them are in the Front Range, with Mesa County on the left being that other 1 out of 10 county that has the highest count. And you can see El Paso County is very dark. El Paso County, of course, has a lot of veterans, a lot of active duty members, and El Paso County has its own county task force. It needs extra attention, and we all know it needs extra attention, so we're definitely working on that. The two main points of this is that, of course, where more people live, that's where more deaths are going to occur, but we also can't forget about all of the rural areas, because rural areas, they can be harder to access care. There can be different cultures that maybe influence whether people seek care, so we can't forget about the rural veterans as well. So we kind of identified 6 different reasons that we think play a role in what creates our Colorado suicide risk. So one, we've identified that there is a higher gun ownership rate here, and as those couple slides ago were alluding to, is that most or 69% of firearms or suicides are caused by firearms. Firearms are obviously very deadly, and so guns equal more successful suicides. It's just the way it is, and so that's why a big piece of suicide prevention is, of course, engaging the lethal means safety component of gun safety, making sure people know about it and can have the potential protections they need if they so want to. Number 2, I just touched on, right, barriers to care in rural areas is always going to be a challenge. Hopefully the expansion of telehealth and telemedicine can support that. Higher rates of substance use, and those can, of course, then affect mental health outcomes. Obviously, an easy thing to note too is that we're one of the few, couple states that have legalized marijuana, so there's just even more access to, legalized forms of drugs or alcohol. Obviously, Colorado itself has a higher concentration of veteran population and active duty, and people often, when they retire, still choose to live here because hopefully we all like Colorado. Number 5 is population increase, which, as I've touched on, more people generally equal higher numbers, no matter what statistic you're talking about. And from that Colorado website 1 or 2 ago, that website also tracks industry. So you can see here that actually if construction jobs and the construction injury has the highest industry rate of suicide. So you can probably take a guess that there's potentially, more males, more young males working in that field, on-off work schedules, you name it. But we do have more and more data even about industry-related statistics. Healthcare is actually, I think, number 2 or 3 on that list. And then this is a relatively new area of research, but Colorado with its high elevation, we know that elevation is starting to, or we've identified that elevation might play a role in how effective medications are metabolized. And if it's not metabolizing correctly, it's not working to its full effect, and therefore it's not playing the role that it could be. So, of course, the key here is, right, that no one issue, organization, or person or intervention can prevent suicide. It's multifaceted, right? So you can kind of see here from the bottom that, individual and population health, up to your social relationships, individual risk factors, where you live, do you have a job, family, right? Like any factor of life you can think about can kind of either be viewed as either a protective factor or a risk factor. So really, when you think about helping a veteran or helping any fellow community member, if you're helping them, you are, in a sense, playing a role in suicide prevention, even if you don't think of it from that perspective. We certainly do here at the VA. So the way we kind of say that is that, right, suicide prevention is everyone's business. Clearly you all believe that, or you wouldn't be here today. Whether it's mental health or any other issue that people need support with, it really is everyone's business. It's our families, it's our friends, it's our communities. You go into any group of people, chances are, right, someone could raise their hand that they're a veteran, and that's important to keep in mind. So part of the kind of pillars, right, of course, we need to connect and reach with the veterans and their families, build community engagement, of course, change the conversation around suicide, right? There is and still a stigma around suicide, around talking about mental health and suicide, asking for help. So every time you have an open and honest conversation about suicide, you're helping change the culture in this country around making it more acceptable. Of course, whatever potential innovative strategies we will continue to create, and there's an Office of Mental Health and Suicide Prevention, which is always working on disseminating best practices, informing policymakers, that type of thing. So every year there's usually a campaign from the National Suicide Prevention Office. Last year was Be There, and this year it is Reach Out. It has dual meanings, meaning one, if you are a veteran, right, please reach out for help. And of course, if you aren't the veteran and you know a veteran, you should reach out to them and check in on them. So you can go to reach.gov, /SPM if you want to check out that. And then, I will transition it over.
Yeah, I think I'm a little too short for that placement. All right. So I don't know if you guys can actually see me standing behind this.
You'll scoot over a little bit.
Well, I might just
There you go.
go ahead and... Does this work? This is... Sure, that'd be great. Oh, the fun of being short. My name is Dr. Musicaro. I am, as they said, a clinical psychologist and the local recovery coordinator. So I want to talk a little bit about the services that we do offer across Eastern Colorado healthcare system to support the veterans. So as you can see on this image, there is a continuum of services that we look to offer at Eastern Colorado as well as across any VA, hopefully, nationwide. All of these services should be based off of recovery-oriented principles. If you look at this graphic, you might notice a couple of things. So the bottom talks about self-directed care. When we think of self-directed care, I think about the things that people often do before they ever reach out to the VA, right? So that might look like anything from peer support, not such as Crystal, but reaching out to their battle buddies and people that they served with, right? It could be talking to their trusted friends and family and supports, assuming they have ones that they feel comfortable speaking with. It could be looking at some of the resources that are online. So the VA has veterantraining.va.gov, which has some veteran-facing skills on there. So there's a parent training, there's one called Moving Forward, which is a problem-solving therapy. There's one targeting anger management. So it might be looking at some of those different resources. It could be utilizing the phone apps, whether they're the VA phone apps or utilizing some of the non-VA phone apps. But either way, usually before anyone ever tries to come into the VA, they try to figure out whether or not they can white knuckle it on their own. And so whatever resources they utilize, that's the self-directed care aspect, right? The main way that they come into our system is called primary care mental health integration. Has anybody heard of this term before? PCMHI. All right. So fun fact, every veteran that receives health care from the VA is assigned to a PAC team, which is a patient care alignment team. Patient alignment care team? Primary care providers, nursing staff, all of those fun supports. But attached to every one of those primary care teams is a clinical provider, whether it's a PCMHI does have psychiatrists in Colorado, luckily, but they're typically social workers, LMHCs, LPCs, or psychologists. And they're integrated in to where the idea is if primary care or nursing assess that veteran and recognize that they might be having some difficulties, whether it is with mild to moderate anxiety or depression or health-related worries, anxieties, they tend to pass that veteran off through what we call a warm handoff to their primary care mental health integration team. So that clinical social worker or therapist will usually meet with the veteran a couple of times and see whether or not it's just needing a little of support or extra skill building. And if they recognize that that veteran's gonna need a higher level of care, then they move on to mental health. They can refer up to that. And that is where I would say the majority of our veterans tend to house, right? So general mental health, we see everything from non-combat related PTSD, so childhood, relational abuse, those sorts of things, bipolar disorder, schizophrenia, schizoaffective disorder, anything in between. So in general mental health, and I'll talk a little bit more about that in just a minute, so I'll keep going. As we move up this continuum, it becomes more and more specialized, right? So as you move up to the continuum, it's going to be a higher and higher level of care. So there's going to be a greater emphasis and demand on what we are going to want to support that veteran in order to meet their unique recovery goals. That being said, if you notice on the side of that pyramid there's still self-directed care. So the elements of recovery say that recovery is not something we can do for you. Recovery is not a target. It is not a goal. It is not if you come in and you do what I tell you to do, because I am the doctor and I clearly know best, then you'll be okay. It doesn't work that way, right? So at the end of the day, there's always going to be two experts in the room. The VA provider might be the expert in what is relevant as far as diagnoses, treatment options, so on and so forth, but the veteran's always going to be the expert on themselves. And so in order for us to really support the veteran, we want to encourage them not just to utilize the services that we have to support them in their recovery journey, but to continue to utilize the services outside of the VA, right? Continue to utilize those phone apps, continue to utilize the online resources, the peer support, which is a wonderful resource, and Chris will be talking about peer support in the VA in just a moment, but there's a lot of peer support opportunities in the community too. So there's an organization called Warrior Now, and it's built off of the basis of peer support. They have daily buddy check-ins every day at 7 p.m. through digital meetings. Continue to utilize that if and as needed, right? NAMI, the National Alliance on Mental Illness, has a wonderful variety of different peer-led and peer-to-peer programs. So we want them to continue to utilize the services within the VA, but also start to build that network of support outside of the VA, right? Build that continuum so they have that wraparound care and they have the resources, not just during the hours that we're here, but whenever they might need it, even long after they stop coming into treatment and after we've reached their goals. So let's talk about goals. I say the word recovery a lot, all right? When people hear the word recovery in the context of mental health, the first thing they tend to think about is substance use. That is not what I'm talking about. while it is important, it is certainly an element. When I talk about recovery as far as mental health, I'm looking more at the idea that when people get a diagnosis, they tend, as those symptoms increase, that becomes the focus. If we don't watch out, that doesn't just become the focus, that can become their identity, right? So recovery to me really is about having a foundation of hope. Hope that there is life after the diagnosis. Hope that you can get to a point that you can use those resources, whether it is in the VA's continuum of care, or if it is more along the lines of that self-directed care and everything in between, to where you can figure out what works for you. What's that combination of supports, of skills, of people, to where you can find that balance, you can regain that control, you can start to get a sense of who you are, not without all symptoms, because recovery doesn't mean an absence of symptoms. It's not a cure, right? So our goal is not to say that you will recover when you no longer have any symptoms of depression, you no longer have any symptoms of post-traumatic stress disorder. No, instead, recovery is trying to find that balance to where, in spite of having symptoms from time to time creep up, you're going to know how to approach them, how to manage them, how to understand them, how to accept them. And you can put them on the back burner and continue to live your life, whatever that might look like. So it needs to be built on hope. And and peer support.
I accidentally touched it.
It's okay. One of the other things to keep in mind is that recovery should be respectful, right? Respectful of the fact that there are two experts. Veterans and any person, regardless of what system you're getting your health care in, you should be given information. And you should be able to give information. Everyone is unique. We have different values. We have different goals. And our goals are not always going to be the same goals as our healthcare providers. If I see a treatment plan that says the veteran stated goal is to maintain my medication, I go to that provider and I say, no, it's not. Because that's the treatment person's goal, right? That's the psychiatrist's goal. The veteran's goal might be, I want to stay on my medication so I can save my marriage, so I can maintain employment, right? It might be more along the lines of I want to manage my anger, but why? What's important to that? So we need to be able to recognize that everybody is going to be different. They're going to have unique experiences, unique cultures, unique backgrounds, unique pasts related to trauma. And all of that is going to come together to inform what is important to them. If we are not figuring out what is important to them, you want to reduce your symptoms, but why? Then we're not going to get them there. People rarely do what they tell themselves that they should do, but they always find a way to do what they want to do. So we need to find a way to link back. Why is recovery important to them? Why is it worth pushing through and learning the skills and utilizing them, even on days when we're still not feeling our best? What's the payoff? Anything you'd like to add?
I just want to definitely add, recovery is definitely nonlinear. And I really like what Dr. Mizukero, what she said about that. Recovery does not mean, the absence of all symptoms. It just means when I speak to, my fellow veterans about it, I'm like, okay, I still have trouble from time to time. But the difference is, instead of it taking me completely out and completely down to a point where I'm again suicidal or can't get out of bed or can't relate to my family, things like that, it's much less. I can identify the warning signs earlier. I can say, okay, here we are. Not judge myself, remove that self-internalized stigma and say, okay, this is a thing, we're gonna address it, here's how I can work on it, and I'll give myself some time, and it just helps you kind of get back on track. So recovery, again, it's having those tools, having the plans in place, having the support, the open communication with your family, and just being able to kind of like bounce back easier.
You want to switch spots?
Oh, sure.
One thing I will add from behind the computer is if you look at this this slide, you might notice that every element has two different roles, right? The role of the VA provider, the role of the VA staff, or honestly, anybody who's touching that veteran, anybody who is in that position to help them, as well as the role of the veteran. Because again, oftentimes this is not something that we can do for them, but it's also not something that they can always do on their own, right? So it's about finding that balance, and we can support them where they need it. All right.
So, yeah, and I agree with that completely. And I like to also share with my veterans, like, you know, the self-driven, the veteran-driven portion, really putting yourself in that driver's seat, taking ownership of the situation, not blaming yourself, not, you know, judging yourself for it, but saying, hey, you know, this is my thing. I'm going to work on it. I always say it's not your fault you were cut or that you were injured, but you owe it to yourself to, you know, take care of that wound. To treat it so it will heal, so you don't bleed on yourself or someone else, you know, and that's kind of how we talk about it. And, you know, I think that's very important part of it. So what is a peer specialist? That is me. So a person with a mental health or co-occurring disorder, like mental health substance use, who has been trained to help others with these disorders, same situations or similar, identify and achieve specific life and recovery goals. So we're kind of like a supplement to their treatment plan with their, you know, psychologists or psychiatrists or social therapists, social worker, whomever. So what we do is we kind of help, you know, collaborate with the team, and we kind of help, you know, help them identify and remember what their strengths are, you know, that are just maybe kind of buried because of what they're going through. So we are actively engaged in the recovery models, which is what we were just looking at, the multifaceted area. And what we do is we kind of model recovery. And so when I meet with a veteran, I say, okay, you know what? I've been in your shoes. We have similar stories. And, you know, I've been there. I know what it's like to feel like that. You're not alone. And guess what? We're not going to judge you. I'm certainly not judging you. This is no different than if someone had diabetes and needed insulin, you know, and monitoring with their doctor. So we're going to get through this. And so we kind of model recovery. While everyone is unique, there are things we can share, like, you know, this is what worked for me. You're unique, you're different. We have, you know, maybe different values or goals or cultures, but here's some things that worked for me. Let's talk with your team. Maybe it's worth a try. And it kind of gives them like buy-in to their treatment as well, because especially with veterans especially, sometimes they have a difficult time like opening up and trusting someone who may not be a veteran. So it can be very beneficial. There have been many times where, you know, a provider has come to me and said, hey, this veteran is having a little bit of hard time relating because he says, I don't know what it's like to be a veteran. Or I don't know what it's like to have PTSD or depression or whatever. And so I'll come in and say, hey, you know, maybe they do, maybe they don't share that experience. However, you know, and try to kind of work together to kind of bridge that and say, hey, you know, let's give it a try. They have expertise in this area. How can we kind of tap into that? And kind of gives them buy-in, you know, and helps them kind of open up and trust. And then we just kind of like walk along with the veteran as they start their journey towards recovery. Thank you. So what do we do exactly? So when we first meet with a veteran, we often share our own recovery story, providing kind of hope and modeling as an example that, hey, you know what? I've been where you are, but guess what? I'm doing so much better now. And this is, you know, I'm so glad I stuck around. I didn't want to at several points in my life, and I'm so glad I stayed around. And so it kind of can give them a little bit of hope. We also help cultivate the veteran's ability to make their own informed, independent, and healthy choices with an emphasis on their own role in treatment. I'm always reminding them, you were in the driver's seat, and you don't have to white knuckle it anymore. I did that for many, many years, just white knuckling it. I can do this, I guess, I don't know. And I just try to tell them, you don't have to do that anymore. Yes, you're still in the driver's seat, but we're here with you. And wherever you're wanting to go, we're gonna see how we can help you get there. So we kind of help them. I always like to help, you know, identify what their interests are or once were, because a lot of them come to me, they're like, I haven't done anything in years. I used to like bowling, or I used to like hiking, but I just haven't done it because I've been so depressed. Or I really liked going to church, but I can't seem to find myself to do it. So I always try to kind of pay attention and dig into those and add, kind of help them find those again. Because like for me, it all got stuck in the muck. Like my strengths were there and my interests were there, but it was all covered up. So I try to help them remember who they really are as a person aside from their diagnosis. Like she had said earlier, a lot of people get stuck in that as being their identity. Well, I've got this diagnosis. I'm bipolar. I guess I'm never going to get better and I'm just bipolar. People tend to forget that, okay, so you have bipolar. That doesn't make you, the disease. It just means that it's something that you have to, learn to cope with. Okay, so what else do you like to do? What are your other goals? Let's figure out who you really are as a person. Let's remember who you are as a person. Aside from that, even though it affects your life, let's find ways to make it affect your life less. So we kind of walk alongside the veteran. I always kind of talk with them about, you're on the path. Inside, you really know where you need to go. But sometimes you just need someone at the fork in the road going, hey, here's some light over here so you can see your way in the dark. Come with me. I've been down this path. I know where it goes. And so it's not something where we just drag them along. Just say, hey, come this way, just kind of walk them along. We assist the veterans with community reintegration and finding connections and supports within the community through resources. So a lot of veterans and people in general with mental health challenges, they tend to isolate. Veterans, when they first get out, like we had spoken about before, it's a very critical time when they first transition. So they tend to isolate. They feel like they can't relate to non-veterans. They don't really do anything. So one of my favorite things is to call them up and say, hey, what are you doing to get out of the house? What are you doing to help on your self-care? Well, here's some resources. Hey, do you want to meet me at the park? Let's get you walking again. Like whatever it is that they used to do or they want to do, I can kind of help get them to a point where they're empowered to do it again or find that again. We do group facilitation and individual peer mentoring as well as advocacy. So we help facilitate various groups that are recovery-oriented, art, music, just kind of like support in general, but they're always with goals in mind to help them get along with their recovery. We also advocate, someone's having difficulty like navigating the VA system, which can be hard. We're right there to say, hey, what's the deal? Oh, okay, well, you're feeling intimidated by getting registered and coming to the hospital, no problem. Told the veteran the other day, I said, I'll meet you at the front door tomorrow. Let's go, I'll grab you a coffee, we can talk, meet each other, and then I'll walk you over and we can get the ball rolling. And that can kind of help with that intimidating factor and that feeling of overwhelm. We help with crisis support intervention under the supervision of a licensed provider. So I do that a lot on the suicide prevention team. Kind of check in with veterans, see how they're doing. If they're maybe experiencing suicidal ideation again, I get a licensed provider involved, a suicide prevention coordinator, and we get them taken care of. Community outreach to educate veterans on VA benefits and services. That's one big thing that's very important and close to my heart. When I got out of the military, I had no idea I was eligible for VA services. Of course, that was back in the early 2000s, and we didn't have anybody come talk to us. I always thought, oh, you had to be, an amputee, you had to be in a very serious situation to use VA services, and that's simply not true. So that's just another, area of what we do.
Thank you. Oh. So I will just say that the value of Crystal and the other peer support specialists cannot be underscored. It was, I think last week, I got tagged on an email that there is a veteran who is not doing well, not engaging in VA healthcare, and every time somebody contacts the person after getting out of the hospital, the response is, you don't understand, I don't want to talk to you, and that's the end of it. And peer support specialists are often in the best position of being able to catch that veteran's ear if we can figure out what is that challenge is acting as a barrier to keeping them from fully engaging or believing in their recovery. A peer can do that. They can talk to them from a veteran to veteran level. The moment they say, you don't understand what it's like, you're not boots on the ground. Oh, but I do. Let me tell you some of the things that I've been through. So it is wonderful. So I want 1,000 crystals. Either way, so this is generally speaking the process of VA healthcare, if we look at that continuum in a different format. So again, people typically enter through primary care mental health integration, not always. Those services tend to be short-termed, usually no more than 4 to 6 sessions, and they're typically very problem-focused, right? But there are some areas to where they do not pass go, they do not collect $100 or $200, been a while, that they do come straight to general mental health. So that's anything with regards to significant anxiety, significant depressive symptoms, any sort of what we call serious mental illness. So any diagnosis of bipolar, schizoaffective, schizophrenia, obsessive compulsive disorder, whatever it might be, they usually come straight to our BHIPs, which is our behavioral health integrated programs. So those are teams of therapists, psychiatrists, nurse, and peer support specialists that own a group of veterans to where they should know everyone on their healthcare team. So if they come in and they just initially say, I don't want to talk to someone, just give me a pill to make it better so I don't have these nightmares, they can see the psychiatrist and they can get their prazosin for a little bit. And when they're starting to feel like they might be ready to talk to someone about why those nightmares are occurring, the psychiatrist can give them a very warm handoff to tell them exactly who they could be working with and facilitate that introduction. So that to me is a very powerful thing, to have that wraparound care to where you feel like everyone on your team knows you and you can know who they are. So it's not kind of that punting from, well, I don't think my docs ever talk to each other. We want to avoid that. If there is something specific going on to where we do have a specialized treatment program, then we'll usually refer up to that if and when they are ready. Not every veteran wants to or needs to engage in a specialized program. Some of the treatments that are evidence-based for post-traumatic stress disorder are intense, right? Someone who is just diagnosed with PTSD and just started to kind of put those pieces together to understand that that's what they've been dealing with for the past 15 years. That's what they've been trying to white knuckle it through. Probably is not ready to have weekly sessions where they retell their story in exhausting detail and then listen to that audio tape every single night. So it can be a lot. But if and when they are ready for those specialty mental health clinics, we do have our PTSD specialty teams, both in the northern Colorado as well as the southern Colorado. Our substance use disorder clinic, where we do have intensive outpatient services for substance use. Family program, so marriage and family therapy. That is across eastern Colorado as well. It's stationed out of Denver. So if anyone is located in the south, it's usually by VVC or VA Video Connect. So that wonderful ability to kind of dial in and see your providers from home. The Life Skills Center, or the PRRC, Psychosocial Rehabilitation and Recovery Center. So a PRRC is a VA intensive outpatient program targeting individuals living with serious mental illness. So think bipolar, schizophrenia, schizoaffective disorder, major depressive with psychotic symptoms. And this is really focused on an education approach as well as a community reintegration approach. So this is not like the old day clinics of yesteryear. Instead, the goal of these is to give them the skills, the resources that they need in order to rebuild the life that they want, meet the goals that they choose, and how to reintegrate in their community. All right, so they do a lot of outings and a lot of kind of getting out of the VA. Intensive Community Mental Health Recovery Services, or ICMHR, ICMR is how they're pronouncing it these days. That's also targeting our severe mental illness veterans, or veterans living with SMI, and that is when individuals have had I think the cutoff is 3 hospitalizations in 12 months. So if there is someone that we see is just needing additional support that the outpatient is not able to do, the ICMR teams will meet with them at their home weekly. They will help them make sure that they're figuring out how to organize their medications, how to set standards, they're completing individual therapy and increasing sorts of community reintegration, with the goal of helping to prevent further hospitalization, prevent further deterioration, and get them prepared to fully engage in outpatient care as they move forward. Vocational rehabilitation services, wonderful kind of continuum of care. Anything from just kind of assistance with directing veterans to organizations and community places that are apt to hire veterans, all the way to transitional work or compensated work therapy, which is where they can actually work to get the veteran who hasn't been able to work in a very long time and does need additional supports, a position for a short period of time, typically 6 months, at or around minimum wage, tax-free, to start to rebuild their ability, their history of work, with the goal of getting them started, having them be able to work in an area to where they are supported to continue their mental health care, and then graduate on, start looking for continued work in the community. Neuropsychology, they'll do the testing, they'll figure out kind of what's going on, cognitive rehabilitation, so our veterans that are experiencing traumatic brain injury. Health psychology, I need another 45 minutes to kind of go down the list of everything health psychology looks at. Everything from people who are experiencing palliative care, dementia, to sleep health issues, you name it, health psychology probably has a hand in it. HUD-VASH, which is part of our healthcare for homeless veterans. So again, helping veterans that are at homelessness, trying to secure housing first, and then starting to figure out what are their barriers to maintaining that housing and connecting them with the services that they might need in order to start to build their future. And then, of course, psychiatric emergency services. So our ER, right? After that, we do have residential treatment. Valor Point is a residential treatment program for people with mental health disorders and substance use that are co-occurring. And it focuses primarily on housing needs as well as employment. We are in the process of rebuilding our residential program for PTSD, and that is expected to open in, I think the last time I heard it was May 2022. So we'll hope we're on target for that. And then acute psychiatric inpatient services. So if somebody does get to the point to where they recognize and they are having thoughts of harming themselves, or they're not able to white knuckle it on their own, we want them to be able to come in and be in a safe environment where their needs and wishes can be respected, to where they can get a high level of care needed to help them find their feet on the ground again, and then figure out how to move forward. So that would be our acute psychiatric inpatient unit. All right, so remember how I said we need a lot of time for health psychology? That's why. This is what we call our organizational chart, and this is a much smaller version than the full one. So this just kind of looks at what some of our different healthcare systems are organized. So there are the mental health treatment programs that I just went through. They're all the different health psychology spelt out, as well as the support for justice. So veterans that are involved in the legal system, that is where the Veterans Justice Outreach Officers and so on can be done. So whole health is a new approach, and I will be brief because we are pretty much out of time here. I can go to the next one, I think. Sure. Yes. So whole health is a different approach to VA healthcare that recognizes that the veteran is a whole individual. What a novel approach, right? So the idea with whole health is to put in that question of why is your health important to you? And then to start looking at what are the aspirations, the goals, the values that support that. And working with the veterans to start to look at those different elements that can support their whole health and wellness. Go to the next one. So Introduction to Whole Health is offered once a month. It is offered by one of our peer support specialists who is trained in this. And it is the second Tuesday of the month from 9 to 11. Like so many of our services right now, it is offered virtually through the VA Video Connect. All are welcome. Just some resources that we will leave up there, but I believe that is the last slide, and we are out of time. And we thank you all so much.
Well, thank you, Dr. Musicaro, Ben, and Crystal. That was extremely informative. We really appreciate you coming today and the valuable work that you're doing out in the community. We're going to break now for a wellness break, and lunch will be served at noon. So please feel free to network, go outside. There is a veterans art exhibit located out in the hallway if you'd like to look at that. So again, lunch will be served at noon and we'll be reconvening at 12:30. Thank you.
All right, good afternoon, everyone. I hope everyone had an opportunity to enjoy your lunch. If you're still enjoying your lunch, by all means, please continue. Hope you had an opportunity to go outside, and I think we filled out the right weather form today. And you know, if you don't get the right form, that's when it's rain, it's snow, it's too hot, too cold. So I think we did that appropriately today. At least I hope you agree. But I hope you had an opportunity to get outside, stretch your legs before diving into the remainder of our presentations for the day. Once again, for those in the room and those who may have joined us for the live stream, I am Douglas County Commissioner George Teal. It is my great pleasure to introduce to you our next speaker, Daniel Darding, who will share his perspective on mental health, substance use, and disorder crisis services. Mr. Darding is the Chief Executive Officer of Signal Behavioral Health Network. He has been with Signal since 2008. Together with Signal's team, providers, and community partners, his mission is to further the availability of quality, outcome-focused substance use disorder, mental health, and crisis behavioral health services here in Colorado. Daniel's experience prior to Signal was in information systems in healthcare, disability management, higher education, and media. He brings a combination of technical capability, interpersonal skills, and business experience to his role as Signal's CEO. If everyone could please help me welcome Daniel Darding to the stage.
Sure. Thank you. Absolutely.
Well, good afternoon, everyone. I don't know who wrote that bio, but you can judge whether or not I have interpersonal skills by the end of this session today. It's really good to see you all together on such a great day of presentations. It's a privilege to be here. When Barbara asked me to speak, she said, I think the session would be mental health, substance use disorder, and crisis services. I thought, at least that's a nice, narrow topic. There's not a lot to cover there. She kind of gave me some ideas of places to kind of focus, so I'm going to kind of jump around a little bit. I know you've been receiving some excellent presentations earlier today. I know Dr. Werthwein was here earlier talking about the state's strategy for behavioral health reform. And if it sounds good, I'll just kind of highlight a few things that have been developments in the field that are really important to talk about. I do want to kind of talk about the behavioral health reform in the state and kind of touch on that. And then Barbara asked for some time for questions. It sounds like there hasn't been a lot of questions throughout the day, so I'm going to try to say some controversial things and really get people going, if that works. That's the interpersonal skills, right? Right. Okay. So I will kind of note too that, you know, my arrival at Signal years ago, you know, I came from information technology. I was an IT guy. And so my background has really been one of a layperson and really learning so much about behavioral health. And, you know, through that time, it's been something that has really grown, that I've really developed affection for and appreciation for the incredible power of what we can do to help people. And so many of you do on a daily basis. And I think, you know, one of the things that has really helped me in some ways to be able to connect through this position and this responsibility is that I think we all are learning collectively what works, what's effective, how can we reach people better, and that's an ongoing process, and that's been something that I've really been appreciative of how much people have been helping me in learning. So hopefully I can be helpful today in sharing some important stuff, and just appreciate the opportunity to join you all today. You know, the things that, you know, I've really seen too, as Signal's history has really been in substance use disorder services, we've grown to have a larger role in crisis services in the state and have a role in mental health services. But our history really goes back to working with the Office of Behavioral Health to provision safety net substance use disorder services. And, you know, I think especially in that area, and in some ways in behavioral health in general, there's this constant tension between how do we stay grounded in the grassroots, in peer services, and staying connected to where we're at a very organic sort of way, and also think about what the sort of scientific basis, what we learn, where we're growing in our understanding in behavioral health. And it strikes me that like both of those things are really, really key and important, and not losing track of either side of that it needs to be about people, it needs to be about the grassroots, it needs to be about peer services, it needs to be about recovery at a really personal level. Also, continuing to see the growth in science. Medication-assisted treatment is one of those big places that there's been such important value, especially as it relates to the opioid crisis. And I think that, over this last, intervening period of the pandemic, where we have seen, some real intense challenges in behavioral health. For SUD, I'm sure many of you have seen this, but the number of overdose deaths in recent time during the pandemic period has just skyrocketed. In 2020, we saw a 54% increase in overdose deaths in Colorado. It's awful. I mean, the level of intensity of need is just huge. Meth, similar numbers there too, just about exactly 50% increase. We don't have the 2021 numbers fully yet, but I think the trends have been showing, just terrible direction. Never have needed more substance use services than we have ever in this time. When I look at other impacts in SUD too, residential care facilities, we saw the expansion of Medicaid to cover residential services. The challenges couldn't have, just when access to that benefit expands, we're also seeing a tremendous challenge in capacity of residential programs. Social distancing, separating people out in congregate care facilities, there just isn't the level of capacity, and the intensity of the acute nature of SUD in this time has been going up. So individuals who may not have needed residential services because of their acute condition escalation are seeing that need more, and we have less capacity than we have had. In this time, whatever we can do to be able to expand physical capacity, to improve facilities. I believe Commissioner Thomas is on the Behavioral Health Transformational Task Force that is meeting right now to determine what investment dollars should be going to behavioral health out of the big ARPA relief package that's been committed to behavioral health in the state. Being able to think about facilities that are able to protect people and separate people and really modernize for healthcare, residential and other acute care facilities are really important in this time. There's a tremendous cost in delayed care as we see the incredible human toll. Talking about overdose statistics, that's one part of it. It is incredibly sad to see the level of acuity that we see in crisis individual accessing crisis services has been going up, and I think the fiscal impact of not investing now to the great extent that we can possibly do is going to continue to have a toll as well. That's why it's so important to be engaged in things like the Behavioral Health Transformational Task Force, what I'm sure Dr. Werthwein said earlier today about behavioral health reform effort. Now is such an important time to be engaged. Withdrawal management too, I know having worked together with so many wonderful folks here at the county to try to figure out a way in which to make withdrawal management services more accessible in the county. That's an ongoing effort, continuing to partner together to find the right location, to find that service expansion here in the county is so important. And I think that effort is ongoing as well. In recent years, Signal's had the chance to be able to step into a role to support crisis services in the Denver metro area, and that includes Douglas County as well, working with local partners like All Health Network and others, SAFI and other providers who are offering crisis services through the statewide crisis system. I know I see the CRT team back here, and so grateful for the incredible work that you have been doing. I'm sure just like I imagine a lot of what I'm saying resonates, just the level of need, the intensity of what's happening, and how much in terms of responses are happening. We're seeing the same thing in terms of mobile crisis and other crisis services like walk-in center services as well. The intersection between mobile crisis, which is a clinical response, and CRT, which includes either law enforcement support or paramedicine in some cases in some communities, there's sort of the right team for the situation at hand, and that's increasingly available in communities. I think the opportunity is to continue to think about how can we make that dispatch experience really seamless, so that, for example, there's an effort, a pilot in Denver, to really invest in the 911 system being a central dispatch point, regardless of whether it's a medical response, it could be a police response, it could be CRT, it could be crisis, whatever it may be, that it's a centralized dispatch. That's a really hard problem to solve. I've learned a lot about the complexity of 911. I'm sure many of you already knew that, but turns out it's a really complicated system. And that opportunity to be able to integrate and allow the right response regardless of the entry point from a consumer or from someone accessing services or seeking services for someone else is really, really critical. I think we have an almost infinite amount of work to do to be able to bring services together in that way. And mobile crisis, CRT, para response, EMS, all of those different pieces really being as integrated as possible together is really an important opportunity. I think about crisis services for kids too. There is the requirement for the statewide crisis system to serve kids as part of the responsibility, as part of what Signal is supposed to be responsible for. But transparently, I think we have an incredible amount of need for specializing that care, for ensuring that it's really accessible for kids. Just think about the walk-in center experience. There's a variety of individuals who may be in a walk-in experiencing a behavioral health crisis. That may or may not be, something that a kid wants to be brought into or a kid should be brought into. And there should be specialization around what that should look like for kids. I think All Health Network, as I recall, has been working with the county to consider maybe there is the opportunity to have a specialty walk-in center or other crisis stabilization unit for kids. I cannot tell you how important that opportunity could be if we could all work together to try to help facilitate a service like that. I think it's really, really going to be important. The level of intensity, the number of individuals and kids that we are seeing referred to bed-based services, to CSU services, has just been skyrocketing. It'll be things like 5 kids from one school in a night or something like that. It is very different profile in terms of access to crisis services, and being able to step in this way is such an important thing to be focused on. And it's the full continuum too. It's not just crisis services for kids, but it's outpatient recovery services. We have a tremendous opportunity to be able to do more for crisis behavioral health and just behavioral health services for kids. There's a program that is piloted through, not piloted, it's very much not a pilot. It's a full statewide program, House Bill 1258, the Youth Rapid Mental Health Response Program. That is a statewide program that passed in a late session bill in June, very last second, that is really focused on allowing there to be a statewide system really through an online portal that any kid can access, doesn't regard, no ability to pay situation, with no insurance requirement. It's all covered through the bill appropriation, but for kids to be able to access 1 to 3 sessions, brief intervention, kind of reach out for help and try to help get them transition to care if necessary for ongoing services. Signal has the opportunity to be helpful in building out that network of provider organizations. I will tell you, it's supposed to go live here in October-ish, which is like, next week, or the weeks thereafter. I say October-ish. The big thing, and I'm sure this has been an ongoing discussion everywhere here today, is getting enough provider organizations to be able to offer the services. That is, over and again, the one limitation that we're running into. The desire and the funding is there. We got to figure out a way to get the workforce that we need, and that is not an easy and quick problem to solve. It's really complicated, and that continues to be the biggest issue around providing access to services, just having enough of our wonderful therapeutic workforce to be able to offer those services. I know that Robert talked about this a little bit, and if you would, I'd like to talk about behavioral health reform too in the state. I think it's such an important area to focus on. the state through a number, what ended up being about a year and a half through the governor's behavioral health task force, really advanced a series of recommendations. I think it's something like 150 recommendations, if that's what Dr. Werthwein said today. Many of which could be organized into some big categories, but the biggest area was we have to have a strategy in the state for behavioral health. It is something, again, this kind of goes back to me learning over the years and trying to understand things better. It seems to me that a lot of what we've done in behavioral health in the state has been funded through incredibly good ideas, grant programs, pilots, really one thing at a time through legislative action, through appropriation, through grant investment. And those things have been incredible and doing so much good in the world, but we can't stop with a collection of good ideas and excellent programs and strong services here and there. It has to be uniform. It has to be that everyone that's seeking behavioral health services has a basic expectation that they will be receiving the care that they need. In the same way that, physical health is, I'm sure, not perfect, but we generally have certain expectations. If we go to the emergency room, if we go to our doctor, here's the things that will probably happen. We generally have certain expectations, and that's really hard to do in behavioral health, not because there isn't a will, not because there isn't wonderful people working in it, but a lot of times because at a state level or how funding is organized or what those different components may be as limitations regulatory, overlapping and complicated regulation that probably doesn't get reviewed and updated as often as it needs to, it can really make isolation be the rule of the day for how behavioral health services are structured. And the behavioral health reform effort is really intending to say, okay, we must have a strategy, we must have a baseline expectation for what services should look like, what the common expectation from a consumer standpoint should be for their care. And there should not be breakdowns, whether it's rural or urban or frontier or level of need or financial ability or whatever the consideration may be. That has to look different than it does today. And I don't think it's sort of not that way because there isn't the desire. No one wants to see things be complicated and difficult. But I think it's because that extra step of thinking about there being a strategy to what we're doing and organization is really important. Behavioral health programs are scattered through, I think, 10, 12 different state departments. Did Robert show the like whole bunch of sort of state departments and all the arrows going off of it? It's just like, I can't process it. It's so complicated. And being able to pull in all of those resources into one place and have it be a program, a system that is from the ground up thought about as interlocking and interrelated, I think is really important. There's intuitively, when I see that too, I think there's a fiscal inefficiency to that too. There's duplicate services here and there, again, for good and important reasons that those programs are started, but I'm certain that if we can organize everything in one place, we will see resources freed up that then can be used to expand to address future and additional needs. We can be so much more efficient by virtue of rethinking that. And I would say, this Douglas County is extremely influential in this process. Barbara, of course, has been on the executive committee of the behavioral health reform effort and has done an incredibly good job in helping to push forward the priorities of that effort. And I think it's so important for all of you to continue to hold the state and what that plan describes accountable, to make sure that it doesn't sort of fall by the wayside because of its complexity. It's important because it's complicated. It's important to push forward because it's ambitious. And I think it's really important for us to all of us do everything we can to say, no, we're not going to put forward a blueprint and sort of, move on to something else in future years, but to say, no, we have to move forward. And I think you all have a lot of influence in doing that. And I would just encourage you to continue to, move that forward. Talk about what you've been able to do in the county by, bringing everyone together. I mean, the Douglas County Mental Health Initiative is exactly that kind of structure. It is exactly those organizations signing a collective release to be able to share information and work together is exactly the kind of, no, we're not going to isolate each other in different pockets. We're going to have a uniform system, and that's what we need to see in the state. I think it's really, really important. I'm sorry I'm getting a little fired up about that, but I just think that's another thing that I've observed, kind of getting to know how everything works. Like it kind of blows my mind sometimes, like how hard it is. I have at a personal level had people that I know that have reached out for help, and time and again, I'm hard pressed to help them, and I have a higher than average knowledge base about what services are available, right? And that really bothers me a lot. And I think that's why we cannot give up on this objective. It's so very important. I think, how am I doing here? Okay. I know, thank you. That was amazing. I read your mind, 5-minute warning. I want to save a few minutes. Barbara asked to make some time for questions available, but I do want to say one more thing. There's been, increased calls around transparency in behavioral health. Where's money going? Who's responsible for what? Why is there breakdowns here and there? And I think those are really important, calls. I mean, the level of investment just in the last 5 years in behavioral health has really exploded. I mean, there's a lot more resources going there. It's questionable like what the right amount of investment is. I think that's something that we don't have good information about yet. But there has been a lot of growth, and I think it's appropriate to say, to whom much is given, much is expected. And I think that call for transparency is important. I think the way that it often gets manifests is, show me the spreadsheet of this thing, or show me the documentation around how this contract works. And those, I'm a big believer in transparency of, government, and share information and make it available to everyone. It's a responsibility of public funding. I think also coming back to thinking about how you all have interacted with each other, sitting around the table, whether literally a table or a Zoom table, that's transparency. And I think that is the kind of transparency that is the most important transparency. When we know and understand one another and are able to understand different components of the system and work together, I think that's the call to transparency that is most important. And I think that's ultimately, in a way, what we seek. We're trying to get insight. How does everything work? I don't understand why this thing over here is so broken, right? How do I understand that better? Well, maybe give me some spreadsheets about this or that. And often that doesn't provide the level of insight that the human connection that literally sitting around the table can offer. And to whatever extent, that's something that Douglas County can continue to push in the state. I think they really need to hear that story about what you all have been able to do here together. And Signal has been able to be a small part of, but it has been a rewarding part to be able to see that. And I think pushing forward for those reforms in our state are really, really important, and all of you have such an important influence in that. So that's what I have to share today. I'm sorry it's kind of all over the place, but I don't think I could cover the entire behavioral health field in 30 minutes. So is there any questions that I could answer, or anything that would be helpful, or controversial statements that you want to challenge that I made? Doesn't even have to be related, just any questions that come to mind, I guess. Yeah.
Hi, I'm Bridget. We have a well-being initiative at St. Andrew, and a lot of the focus today has been on treatment and downstream. Mm-hmm. So when we talk about upstream and increasing protective factors, what would you like to see more of in the community? What are some gaps we can respond to and make happen?
I mean, it is true. All of the investment so often is in treatment and acute services, right? So we wait till there's a big problem. We wait until services are in, the most intense services are needed, and that's where we focus our funds. And that's been the case in behavioral health and substance use services forever. I mean, it was all about treatment. Signal, in our history, for the most part, it was all about residential, some outpatient, withdrawal management. That was the core of how we started as an organization. And only in recent years have we been able to receive investment funds that we can distribute to communities for recovery services. So when we're talking about building out a full continuum, it has to include recovery services comprehensively across the board, everywhere. People should have access to recovery services, and they need to be tailored and specific to, populations. So, services to provide, recovery support for kids look very different than for adults. And in a lot of cases, you want to integrate that really well with prevention and how early intervention services could work. The Youth Rapid Mental Health Response Program is, in a way, intended to be a very early, hopefully early, low barrier, brief intervention kind of, interaction of services, assuming we can have enough providers available to be able to pull it off, which, is sort of like going to be impossible, but is important as a starting point. When we neglect parts of the continuum, I think that's sort of that delayed care impact, right? That we see acuity of services really escalating for individuals if we just got to them sooner. If we'd got to them when the seeds of addiction were starting in adolescence, if we'd been able to be there and provide the right services at the right time, it has to be a full continuum. I don't know if that's helping to answer the question, but.
I guess the follow-up is, if you think outside of the behavioral health system,
Yeah.
what can we community partners provide that you really see a lack of
Yeah.
in that community?
Yeah, I think, again, the way in which, it sounds like I'm pandering perhaps, but I am not when I say a good idea can be a good idea, right? What the Mental Health Initiative has been able to do has been able to bring a ton of different types of organizations together to think about whether it's awareness in a school-based setting, prevention services in a school-based setting, how can we work together with child welfare in the right way to identify the right and appropriate level of care for kids, for the reform effort around family first prevention services, right? That is intended to reduce residential care for individuals. The type of service plans are put together are not just treatment based, but here's here are environmental factors that are affecting kids, food security, and other sorts of things that may be affecting kids' outcomes. All of those things have to be brought together. Behavioral health is not, to your point, just about treatment. Yeah. Other questions? Critiques? All right. Well, I don't have more than just to say thank you for what you all have been able to do and model for the state. Just please continue to keep it up. It is a privilege to be. Oh, yes. Yeah, the youth well, it's not launched yet. Yeah, right. Yeah, it's literally supposed to be launched in the next few weeks, and we still have a lot of work to do to get the right number of providers to offer services. But it's called the Youth Rapid Mental Health Response, House Bill 1258, passed last session. The Office of Behavioral Health is the agency responsible for it, and Signal's helping to support the build out of the provider network. But it will be launching in coming weeks, and it's going to be a ramp up launch, I'm sure. We are anticipating that the demand will be greater than the available capacity, but at some point we need to be able to roll it out and just start building out those services. So that's what that is. Yeah, that's for kids. Yeah, so consent law in Colorado around children's behavioral health, right, is depending on the sort of services being accessed between 12 and 15 that requiring a parental consent. We could probably debate that. That's a controversial thing. I'm not going to probably do that here. But that is the law in Colorado between those two ages. But we are encouraging parental involvement. A big part, I know, of the OBH campaign will really be to encourage parental involvement in referring their kids to services and helping to support that. That's really the intention. A lot of times the need is for family-based care too. It's not just about the kid, it's the whole family. All right. Well, thank you for allowing me to be here with you all today, and really appreciate that.
Hey folks, thanks for sticking with us through the afternoon slog. We're almost there. But now we get the fun part. We get some youth voices in the room. They're missing school for this, so yeah. But we really appreciate their time and really the ability for us to be able to hear directly from some kids and their experiences in schools and within the community itself. My name is Austin Good. I'm the Assistant City Manager for the City of Lone Tree. And one of the highlights of my job is I get to help out with our Youth Commission. So the City of Lone Tree Youth Commission is a group of about 9 students that live within Lone Tree. And their main task is to advise the City Council on youth issues. So they've done projects and advising on everything from tobacco policy to mental health to hunger in Douglas County schools. Over the pandemic was actually a project, and actually Laura might let you talk a little bit more about that. But we're really, really excited to be able to bring 2 of our youth commissioners up to speak about just their experiences and what they're seeing in the community. We've been hearing from a lot of experts today, and I've learned a lot myself, and I'm really, really excited about that. But I think it's a really good thing sometimes to just kind of do a check with some folks that aren't plugged into the mental health world all the time, and some youth that aren't thinking about this maybe every day, to see what their experiences are and what they're hearing and what resources they think are available to them, and maybe seeing where some of those disconnects are. So with that, I'll let you each introduce yourselves. If you want to just kind of shout out your name and your grade, school you go to, and also why you joined the Lone Tree Youth Commission.
Cool. Hello, my name is Laura Polito. I am a sophomore at Highlands Ranch High School. In addition to being on the City of Lone Tree Youth Commission, I am a volunteer for Lone Tree Teen Court, an alumnus of the Colorado Student Leaders Institute, and I also run cross country, which is pretty cool. I first joined the Youth Commission because I wanted to give back to the community that welcomed me when I first moved here. It's incredibly important to me to be able to help out in this community that helped me. And the best way for me to do that at my age and at my stance in life is to be working with the Lone Tree Youth Commission and helping the youth in my community. So pass it over to you, Maddie.
Hi, I'm Madeline Geiser, and I'm an 8th grader at St. Mary's Academy. And in addition to the Youth Commission, I give tours at my school for new students, and I am a swimmer. I joined the Youth Commission to inspire positive change in my town. Thank you.
Thanks, Maddie. And I also want to give Maddie a shout out. So her first youth commission meeting with the city council was this Tuesday. So she's fresh into the commission, and I think this is a really good way to get started. I think you're setting yourself up for some success here. So, we've talked a little bit about the youth commission and the overall goals. Do you want to talk a little bit, Laura? Maybe this is a good chance for you to jump in about just some of the projects the youth commission's done, and maybe even the project that you took on last year.
So the Youth Commission does take on a lot of projects because we want to help give advice towards the community. And so one of the projects that we did about 2 years ago is the It's Not Nothing event, which was a mental health night where the City of Lone Tree invited 4 speakers to come talk to a crowd of 200 plus people about mental health as it relates to youth and just the community in general. We also wrote a ordinance for tobacco and e-cigarette law because we think it's important to protect the youth from e-cigarettes. And last year, we also attempted to address food insecurity around our city by raising money and giving money to schools to pass out for kids who are in need and their families so that they can have food to eat. Yeah.
So you guys have been pretty busy, which we really appreciate your work, and it's definitely, again, you see why it's a highlight of my job to be able to get to work with them. So pivoting a little bit onto the mental health side, can you each maybe, and maybe it doesn't have to play into mental health specifically, but just thinking about the pandemic, what are some of the impacts that you saw over the past year or so that affected you or maybe affected your classmates?
Well, my school was remote for a good portion of the last 2 years, and that has definitely affected some of my classmates' relationships with each other and their relationships with their families who live far away. And, you know, that's very hard for them. It can feel very detached, and one way to combat this is just making friends and starting anew and just connecting any way they can.
Yeah, so there's definitely like a large feeling of isolation and anxiety about going online and not being able to be in person with our classmates and our peers. I think even for adults, this was a pretty tough time going through the pandemic, where you're not able to see your family, you're not able to see your friends, people who you have relationships with, and that's really tough on your mental health, especially. I think also just for me and like my classmates, there's a lot of anxiety about we're losing a childhood and we're losing our youth to this pandemic, right? Because there's so much stuff that I was really excited about going into high school, and I wasn't able to do that. So it's for sure had a large impact. Yeah.
Oh, thank you both. So thinking about the stigma around mental health, you know, that's something that we talk about often is, you know, making it okay to not be okay or making it okay to talk about things. Can you talk a little bit about what your generation or what you see, you and your classmates, how you all feel about, you know, the stigma about mental health? Do things feel like it's becoming okay to talk about, or does it still feel like it's almost like a shame to be dealing with some sort of issue?
Well, in the past, mental health did bring about negative feelings, but especially with the pandemic, our generation knows what it's like to be stressed, and we know that the best way to get out of that is to be there for each other. So we do talk about it openly, but if there ever was something going on, they know to go see a therapist or seek help in some way or form.
I mean, ultimately, mental health is never going to be treated the same as physical health because it doesn't always have physical symptoms. So people are always going to see it a little bit differently. And I think especially for our generation, though, there's been sort of a more openness to it with like the rise of the internet, where people are able to speak about their emotions online with anonymity. And it provides a lot of a sense that like we're not doing this alone. Like a lot of what you see is like, I'm going through that too. They're going through that too. I can talk about it with them. And I think there's also like a lot of people are more comfortable going to therapy, right? A lot of people are more comfortable going to talk to trusted adults or their friends about what's happening with them so that they don't have to feel in such a way. So
Oh, thank you both. And actually, I'm sorry to jump around. I noticed I did skip a question. It's okay if there's nothing more to add on this topic, but we talked about the impacts of when you were going through the pandemic. Do you have any other thoughts about maybe some longer term impacts, or maybe now that you're back in person in school, is there anything that you're noticing that's different now that you're with your classmates?
There's one population of students that are disproportionately affected by the pandemic, and that is the very young kindergarteners and first graders who, as soon as they were thrown into a school situation, it was shut down. And now I'm afraid that some kids might be anxious in crowds or how to make friends. And now that they're thrown into that situation a bit later, I feel like the teachers and parents need to figure out some way to combat that and be there for them if they need it.
So I think especially for my classmates and I, it was really difficult going online, and then going on person for a lot of people was even harder, because after being online and being isolated from your friends or your other family, it can be difficult to step out of your shell again and step out to continue making relationships, start talking more to people where you didn't have to do that online. Online, it's in many ways it's harder, but it can be easier because you don't have to show your face and you don't have to maybe show vulnerabilities, which you have to do when you're in person. So that's definitely something that it's going to be a lot difficult. It's going to be a lot more difficult for kids to be coming back into this situation.
No, thank you for that. So, switching gears a little bit back to what we were talking about before, there was just, thinking about stigmas around mental health, but also thinking about kind of what your personal actions would be. So maybe put yourself in the shoes of maybe you being the person that needs help, or maybe you have a friend that you find out is going through something that they need assistance with. How would you go about that? Do you have any resources that you'd point them to, or if you don't know what you'd do you know who you might go to for help?
Well, I would try to help my friend if it was less severe matter. But if it was more serious, I would tell them to go talk to a teacher or the guidance counselor. And from there, those people can help them find even more trusted adults. And hopefully, the situation will improve.
It's for sure difficult to be going to have a friend come talk to you about what's happening to them in their lives and about if they're feeling depressed or suicidal or something along that lines. It's something that's really important to me, that I try to talk with them and find out how I can help them or how I can get them help. In many instances, that can be difficult because, I don't know, especially at my school and I guess just it can be very difficult to go to an adult about something that someone else is going through, or even what you yourself are going through. With a lot of adults, they don't take the time to build connections with us, to make us feel safe, to be talking to us about what's happening with us and about why we're feeling like this. So it's something that I feel a lot of schools need to improve with, like, providing these areas where people can go to. And I think even with a lot of resources and a lot of companies that are dedicated to helping us, it's difficult because they don't always provide ways to actually talk to them, or they don't have enough awareness about how we go talk to these people, about how we get our friends help.
Thanks for that. So staying on that resource train, so thinking about what mental health resources or what counselor resources might be available to you or a friend, or someone that you care about. Can you let us know, just off the top of your heads, what do you know that your school provides, or have they done anything to get the word out about different resources, or even thinking about the community at large? Maybe it's not something that came from the school, but something you heard somewhere else. Is there any resource or anything that comes to mind?
I will say that my school does a phenomenal job, in my opinion, of spreading the word about mental health. We have a program called Sources of Strength, where there are posters throughout the school of a pie chart that show different categories of trusted adults that you can go to when things get tough. And in addition, they've trained teachers to listen when kids have something they want to talk about. And I know there's a club in my high school that focuses on mental health and how to improve kids' self-esteem and behavior and other things like that.
Yeah, so like she said, Sources of Strength is also something that's being launched at my school currently. So over the summer, they provided training to teachers in order for them to be able to deal with more of the mental health aspect of teaching, because that's always going to be something when it comes to teachers. They have a relationship with these students. In addition, our counselors are always available to us, although that's not always something that students first think of to go to, because they don't always take the time to build relationships with us. And also with Sources of Strength, I believe that they are doing a program where they're trying to create a peer leader program so that, as well as teachers, other students can help or can lead the way in helping with mental health at our school.
No, I think that's interesting program. And until I started working with the Youth Commission, I hadn't heard about Sources of Strength before. So that's something new since I was in school. And I think it's one of the things that, personally, in my work with youth, I hear that as a pretty repeated theme of something that the word's gotten out about and folks are familiar with. And so I think that's a really good, positive thing that both of you were able to point to that, because I know actually the work of a lot of people in this room went into that as well. So I think that's a testament to a lot of the hard work that's happened with all these folks. So thinking about mental health resources and knowing that there might be things available but that maybe you don't know about, or maybe there are missing resources where you've gone out and tried to find something and it wasn't there. Is there anything that comes to your mind that you think that schools or the community or organizations like the Mental Health Initiative could do to get more resources in front of you or make them more easily accessible?
I think that they just need to keep doing what they're doing, and maybe if that includes behavioral health or mental health at local health care facilities and getting the word out about that, as well as training our law enforcement to handle situations where they might be called in for a psychiatric emergency. I know that police men and women are not trained psychiatrists, but I don't want them to, look at it as a bad thing. I want them to be considered more as helpful people in that circumstance.
Yeah, so surprise, surprise, a lot of teenagers don't like to speak about their feelings.
What?
So I think it's just important for schools to continue building these relationships with students, continue making avenues for students to come get the help that they need. And also I think coming to schools, coming to talk to our schools, making more social media and having events tailored towards students so that students will be more inclined to learn about what what resources they're able to access. It's really hard as a teenager to go and talk to parents, especially to teachers, because it can almost feel as though you're disappointing them when you're coming to them with mental health issues. I just think that creating these more programs, creating these relationships, that's what's ultimately going to be the difference in a lot of teenagers and people's lives.
So actually, Laura, if you want to hold on the mic, just to build off of that. So, sure, teens don't like to talk about their feelings, or, that might be a difficult hurdle to get by. Is there any advice that you'd give to maybe how to initiate a difficult conversation, like for an adult or a mentor or a parent or a teacher to be able to break the ice or introduce that conversation to a teen if they see, hey, something might not be right?
Actually, this is something that I talk about a lot with my friends, because it's important for us, for a lot of times, since it's difficult for us to reach out, sometimes the adults need to be the ones reaching out to us as much as they possibly can. And I think creating an environment where people feel safe to talk about mental health and not maybe putting people down for their mental health problems that's like number one. That's most important, because if you don't feel comfortable, if you don't feel safe, you're absolutely never going to talk to somebody about this. Yeah.
Yeah, Maddie, I don't know if you have anything to add on that front.
Yes. So I think that if parents or other trusted adults want to have a conversation with their children about mental health, I want them to start by saying it's that these things are real and they are difficult and they affect many, many people. But if you ever feel like that, there is always someone to listen to you, to help you, and they will never judge you. And there are several resources to go to no matter what. And that they always have to believe in that and not give up on themselves.
I think it's also easy to feel really silly about the problems that teenagers are facing, because for a lot of adults, this isn't really anything, right? Some of what we're facing. But it's just important for adults not to put down what we're saying, what we're trying to put out, and listening to what our kids are actually saying, right? Because sometimes they'll say stuff and it can sound like a joke, or it can sound really silly. It can sound as though it's something small, but it's not a lot of the time. And just paying attention to what they're saying, paying attention to how they're saying it, that's really important for us so that you can reach out to us or we can feel comfortable reaching out to you.
Great, thank you both. Is there anything else before we turn it over to the hyenas out in the audience? Anything that you came into the panel really wanting to make sure that you got across or wanting to make sure you said? Or did you feel like you got everything you wanted to say out?
I mean, I just wanted to thank you for putting on this event. It can be so difficult to talk about mental health, but I think it's so important to have these initiatives to talk about how to better improve people's lives and how to better improve people's mental health, which is so prevalent in our community today. So thank you.
Yes, as Laura said, raising awareness is the best first step that we can take towards solving an issue. And I really appreciate what all of you have done to contribute to this field and help us get where we are today. Thank you.
No, thank you, both of you, for your time today. We can turn it over to the audience. We do have some time if anyone has any questions they'd like to throw out there. I'm not sure if we have a mic. Oh, that'll work.
Do you guys feel like it's harder with the mic or easier without it? Like, can everybody hear okay?
Yeah.
Okay, we'll just let it go because then we can just keep it flowing.
We'll make it work.
My name's Shylin, but I'm not shy, so I'm sure you probably can hear me. I don't have a question. I just wanted to say thank you
impactful legislation and policies. Amazing work, and really appreciate that passion. And we want to continue to work with you. But we have partners here. I know Douglas County Healthy Youth Coalition, a lot of our members are here, but we also have partners with St. Andrews and the Aspen Effect. How can we better connect directly with you? Because at this point, we tend to leave all the responsibilities on the institutions, and that's not just a Douglas County thing. Here we go. We're going to pile one more thing on our education system. Oh, we're going to pile some more on the police officers. So what can the community do, or organizations like ours, better connect with you on things like sources of strength, like explode sources of strength? This could be used among adults to bring more awareness and these skills. So what suggestions do you have for us to connect better with your peers?
That is a great question. And right now I do have to admit something. The first time I heard about sources of strength was maybe 2 days ago. It's something that's really cool that my school is implementing, that the district is implementing, but it's not something that any of my peers know about. I even asked my peers about this. I was asking my friends, like, what resources do we have? Like, who do we go to besides maybe our counselors? And how do we learn these skills? So I think it's more important to be talking to youth specifically and to be creating programs that are, not programs, but more like events where youth can come and they can learn about this. Like events that are tailored specifically for youth, to buy these events, to buy these companies to learn about. So, yeah.
I think events like this are a great way to connect with the youth, but you also making an effort to come to their schools or daycares, in an age-appropriate way will always make a difference. And I really liked that idea you had about using sources of strength to help adults, because those concepts of if you need something, say something, is always universal.
Also, getting out there on social media, making maybe ads on YouTube that while we do want to skip, we can't, so we have to learn about it. And I think that's something that will ultimately get the attention of a lot of youth and a lot of kids. So, yeah.
Do you think Chris should start a TikTok?
Absolutely. Absolutely. I look forward to seeing your dances on my For You page.
So I'm going to piggyback on that because we want you as youth to have trusted adults that you can communicate with, that you have access to. And like you said, the counselors in the schools, they're overworked and they don't have the capacity to get to know individually. What type of a program could be put in place, like a trusted adult program, do you think? And what type of accessibility would you like to see with that as adolescents? Did you want to do this texting? Did you want telehealth? How would this look?
Well, as we talked about, Sources of Strength is an example of a very helpful program. But as far as accessibility, one platform I really like is Talk Now Colorado. Forgive me on the name, but it's a platform where you can write anonymous messages to the principal of your school or to local police officers if there's something that's troubling you, and they can work at the root causes of that to try to make it better for you. And a trusted adult program would really benefit from anonymous letters, because kids don't want to be singled out, and using their names can embarrass them or make them feel like they aren't doing anything right by talking. But that is needed, and that is what we are trying to do.
I wholeheartedly agree. I mean, kids don't like to talk, and having that anonymity makes it so much easier, right? And I also think that in many ways, having a trusted adult program is needed, but in a lot of ways, that often falls to teachers, and that's a lot for teachers to handle. So maybe providing teachers with somebody who they can bring these kids to instead, because kids, they're close with teachers a lot of times. So if they go talk to their teachers, and their teacher can direct them towards someone that they can trust and that they can, instead of just leaving it on the shoulders of these teachers who are already working incredibly hard.
So you're looking at community members then? Maybe where in the community we can sponsor teachers to be a trusted adult for them. Is that something that you're thinking?
That could be. It's just not something that I necessarily want to put on the shoulders of a teacher, because I feel like teachers already deal with so much that's a lot to handle. So, but that could be something that you look at, or that could be something that could potentially be put in place.
And I agree with you completely on that statement. I have a friend who is a teacher in Douglas County, and when I took my job and started talking all about the things that we do in where I work, that was the first thing she said. She said the teachers are so close with these children, the teachers really don't know where to go to make sure that the kids have the resources that they need. And so maybe arm the teachers with resources of people who can then protect those kids and get them to the right resources, because the counselors are busy doing schedules and college prep and all the other things that the counselors do, and sometimes that other piece of the need for help maybe won't get met immediately, whereas if the teachers have more information directly on someone to contact to say, okay, who do we go to offer this child the support that they need? So I agree with you 1,000,000%.
Dr. Caroline Kopp, I'm a nutrition and behavioral specialist. I sit with people like yourself all day, and again, I vastly appreciate you Mr. Dunkel and sharing this information. I think what I'm hearing you gleaning on, I always think, I felt before is needed, is more of us into your school, in your faces. More of the people who understand what face of mental health what it looks like. A lot of students don't even have an idea. I didn't take interviews and like, well, I didn't know, like all kids don't do that, no. And parents think like, isn't that normal? All kids are punching holes, teenagers are punching holes in walls. No, that's not normal. And the parents don't understand what the face of mental health looks like. The teachers think they understand. They still miss such a big still. Anxiety, I can't tell you how many IEP meetings I attend, and you hear teachers say, I see no anxiety in this child, and I don't see it in the classroom. My answer is, you can see the diabetic either. Who's sugar 350. It's a chronic medical condition. They can die quietly from tornado ruin inside them, looking like everything's fine, busy people pleasing, and they wouldn't self-advocate. They'd rather go to dentists and have their gums filled. So, getting everyone to understand what it looks like, ask people further questions, build the relationships, and be able to have, even, for example, if a teacher identified a handful of students who guidance counselor did that were struggling, let's get them together in a group and have someone like myself come in, have one of the psychologists, social workers, PhDs come in and talk with these students. If you do it and you do it repeatedly, and they see something on your face, if they start to build a comfort level and might actually reach out for the things that once we get that higher risk identified group, people with more training and specialty in that area can more effectively help that group of students. But I think that all of us in the different organizations potentially have the ability to come together, maybe form another committee to be able to get in, because there's so many schools in the area that are so needed. But I know that I worked for in Aurora with a nonprofit organization as mental health providers. We had a little modular home outside the school, and there was a medical side, but everyone was coming down, getting calls from the nurse, the principal, guidance counselors to come, and I was doing psych left and right with these children, and having the continuity of care where a lot of students, once you start, might not follow up or follow through. If you're there, you can effectively get to them, or via a telemedicine program, they can get to us in real time as it's happening. Because the goal is to keep the kids, to get them to go to school and keep them in school. And once they're there, they can have that FaceTime. Once they've established a relationship in real, at the school, and they can then access them via telemedicine, because relationships have been established, and we can keep them in school and talk to them. Maybe real time as it's happening, grade will do X, Y, Z. That child can't take it home to have it happen with their family.
Kind of like to get your insight on or experience. You talk a lot about social media. Kids live, the youth today live on social media. So there's a lot of positive things in social media, but there's also a lot of negative in social media. And what we've seen in working with kids, and then when we have their phones, and we're working on a strategy over here, and we're looking at their phones, the phone tells us the story of what's going on, and how the kids are being attacked on social media. And then once somebody gets on board, then everybody starts piling on. If an adult had to go through this, I guarantee they couldn't handle it, but it seems like it's an everyday occurrence. Are the kids talking about this, about the social media negativity that's on there, and what resources do they have if all of a sudden they're finding themselves a victim of that type of attack or that type of pressure? Because we can talk about a lot of good things, but it can also be reversed on the negative side of what's coming at them that parents don't know about, teachers don't know about, adults don't know about it, because we don't live on these things like the kids do today.
Well, I'm going to start off by saying that there are many more ways to express yourself than hiding behind a screen. And and though it is fun and interesting to be in touch with people, there's also good old-fashioned picking up a phone. And there are so many ways that social media can go south, from cyberbullying to body positivity, and so many of those photos are engineered, doctored, you name it. And I know that when there was a cyberbullying instance at my school 1 year back, they handled it very quickly by getting parents involved. And I don't know how that affected it later, but it felt very good to know that parents and teachers were there to help us. And there are always settings in place on phones that can make sure that kids don't connect with strangers or people who are going to bring them down. And just controlling that and setting limits that make sense for kids can really make a difference.
Yeah, and a lot of it also comes down to who these kids are, like their role models. Because a lot of our role models on social media, right, they tend to act as though they're perfect, and in a lot of all instances, they're absolutely not. So I think an important thing is with like our role models on the internet, and is also their transparency about how they have dealt with the internet, about how the internet has reacted to them, where they'll often be incredibly negative or they'll provide a lot of hate towards them. And having transparency among people who a lot of young kids or teenagers look up to helps them figure out ways to deal with what they're going through, going to their parents to talk about, like, this isn't something that's normal. Because if you see it happening to your role models and it's treated as though it's normal, then you think it is normal for you too. And it's absolutely not to be dealing with hate and to be being bullied on the internet or anywhere in general. Yeah, and also, like she said, having those parental settings, because kids should not be allowed to roam free on the internet. It can lead to terrible outcomes. So having settings in place on your kids' phones, on Instagram, on Snapchat, on Discord, on whatever, to try and keep them away from straying off the side of the internet where they can benefit and they can learn from, is really important for parents and teachers and all people to do. Let me ask you real quick. If you
to parents around the world, what age would you tell them is appropriate for their children to have a phone?
And actually, to add to this, I'm curious what age you both got phones.
I was pretty young when I first got my phone. I think I was maybe 4th grade, so maybe I was 8 or 9, which is pretty young to be roaming around free on the internet. So I don't think that kids that young should be getting a phone or be getting like access to all Instagram or all these like different social medias. I think they should be getting it at a younger age with proper training and from their parents as well. Like their parents should be talking to them about it, about what they're looking through and putting settings so that they're not going everywhere on the internet. So to be honest, I have no idea what age. Maybe for my child, I would go with maybe around the age of 13, 14, which is really hard for kids these days because a lot of kids are getting them younger and younger. I think my cousin, who I love dearly, got his phone around the age of 10, and that was showing a lot of restraint from his parents because a lot of his classmates already had theirs. By 3rd grade, they had theirs, and that's way too early.
Well, I think that it largely depends on the family and their circumstances. I know some of my friends who have gotten their phones in case they ever got lost from their parents. And I got my phone when I was 11, just so I could talk to my faraway family and text them if I needed help. But as the pandemic started, my social life was online and I was able to call a lot more people, but that too much too quickly is never a good idea. And for instance, my cousin, who I'm very close with, got a Facebook account when she was 10, and to be honest, that hasn't worked out so well for her. And I want to help kids prevent that as much as possible. So parents taking a class, they offer classes like that at the Apple Store to learn how to work their phone for their kids' privacy and safety is going to make a big difference. And if something seems wrong to a parent, like maybe your kid should not be on, I don't know, Snapchat or TikTok a lot, then definitely do some of those measures that are recommended by that Apple class.
Great, thank you both. And can we do one more round of applause for our two young people?
Thank you.
And I know they had a chance to thank all of you earlier, and they're way better at thanking all of you than I am. But again, thank you so much. Again, this isn't my realm, and so being here today and just listening and hearing from all of your expertise and hearing that you're really genuinely taking to heart what folks are saying, it means a lot to me, and I've learned a lot today. So thank you very much. I think it looks like I'm handing it off to Laura. Is that correct? And with that, here's Commissioner Thomas.
How about another round of applause? So, as we bring this inspirational gathering to a close this afternoon, I've had a thought. I wonder, and I challenge all of you to try and find other examples throughout the United States that represent the powerful, passionate, and effective collaboration represented in this room today and joining us online. Look what you all have done. 7 short years ago, the Douglas County Mental Health Initiative was a concept after that horrible murder-suicide just 7 years ago. This group came together with a single idea in mind: uniting our community partners with a collaborative spirit. I'd like you all please to stand. So as we wrap up this day, I think it's really important that you all give yourselves, including Terry over here, a round of applause. So each and every one of you standing in this room today are the reason that the Douglas County Mental Health Initiative continues to make a difference in people's lives. We thank you. As a county commissioner, George is here with me. The county commissioners thank you for what you have done, because you are making a difference every day in the lives of our citizens. We know that we have to continue doing this together to make this difference. So as you leave, I would just like to ask that God bless you, and we look forward to working with you in the future. Thank you again for being here.